So the meeting is open to the public. It will be broadcast. Sorry, it will be recorded and broadcast online. In the public gallery, everybody's feel free to use mobile devices as long as they're in airplane mode. All devices are muted. It isn't permitted to take photographs or record any of the meeting, but just to let people know that because we're outside of Parliament buildings today and because of a bit of media interest, that there will be some media taking photographs at the very start of the meeting, just in the first couple of minutes. So, any apologies? No? Okay. In terms of chair business, this is going to get really annoying.
Who's in charge of our Zoom?
Okay. Can I just make sure all members mute themselves, if possible, until such times as they've been brought in? Okay, so chair's business. 4 of us of the committee attended the Mater Hospital yesterday, the 26th. So we had a really good conversation with the staff there in terms of the mental health pathway services offered. I think everybody was impressed by the potential that service has, both in patient outcomes but also in freeing up emergency departments and other aspects within the healthcare service. So, a big kudos to the staff involved in that, and we're aware that they have a business case and for the Minister in terms of payment and resources and that. So, I think if everybody would be happy that we could write to the Minister just to say that we met, visited the site. We thought it was very useful, the service they're provision, and to ask for an update on the business case. Yep. Okay. We also got our flu jabs, which again was useful for ourselves with regard to protecting ourselves, but more importantly, it created a wee bit of media focus. So obviously we want to use our positions to get the message out there that the flu vaccination protects the individual, protects their families, people they come into contact with, but also protects the health service, particularly with regard to reducing winter pressures. We will have people ending up at our emergency departments over the next few months with unfortunately bad flus, but the more people who get vaccinated, hopefully that can be reduced and as they decrease the pressure on our healthcare. Today then, we've had a busy couple of days as a committee. So today we met with businesses from Enniskillen area and also council reps from both councils within the Western Trust area. Just we had a really good conversation with them over breakfast this morning, and I'm sure members, including myself, will use that conversation when we're asking questions of both SOAS and also the Trust. And then after that we went to the Cancer Focus Centre here in Enniskillen. So I don't think anybody that was there could not have been impressed by the facilities, the modern building, but more particularly the service that Cancer Focus are offering through their staff and their volunteers, counselling services, other very important services for individuals who have cancer and their families. And again, just in relation to that visit, I would ask if members would be content that we write to the Minister just to say again that we visited this facility, very impressed with it and the work that they're doing. We're aware of a couple of business cases and to develop that within hospitals across the north, and that we would ask for an update in relation to that. Everybody content? Okay. And then obviously we're in the Southwest Acute Hospital, and we're delighted to be here for this meeting, and we have had a tour of the facilities. I have to say, from a personal perspective, this is my first visit here. I couldn't not be impressed by the modern facilities within this hospital. It's a huge facility, and I want to thank the staff of the Western Trust for the tour and for accommodating the committee meeting this afternoon. Okay, so that's enough of that. Moving on then, draft minutes. Can I refer everybody to the draft minutes of the meeting held on the 20th? Everybody content with them? Content. Thank you. Any matters arising? None? Okay, so we're moving directly then onto the main items of business. So item number 5, oral briefing from Ciara Acute Services. Can I refer members to papers at tab 5, page 13 of the main pack, and then welcome. So can I just welcome Helen Hamill and Jimmy Hamill and Karen Eccles, all from Save Our Acute Services.
Thank you, folks.
Thank you. Now, put that in my bag. Jimmy.
So you're all very welcome. Thank you very much for attending. We obviously received a written briefing from yourself, so I'm going to hand over to yourself just for some introductory remarks, and then we will take questions from members here and online. And just if I could ask everybody, because of the nature of where we're at, if you could speak as close to the mics as possible. The meeting will be recorded and online. It's important that we are able to pick up everything that's said. So over to yourselves.
First of all, Chair, members of the committee, thank you for the opportunity to speak today. We represent Save Our Acute Services, a campaign formed in response to the suspension of emergency general surgery at South West Acute Hospital in 2022. 3 years on, over 83,000 people in Fermanagh and West Tyrone remain an average of 2 hours away from life-saving care. This is not sustainable, it is dangerous. Winter is here, and already we know that Atnagalvin isn't coping. How could it be? With corridor care running rampant and cancer patients being left on the floor. We know the evidence. Requia told this committee that people are coming to harm as a result of time spent in ED departments and waiting to be offloaded by ambulance crews. NIAS has confirmed delays are leading to increased deaths. The Royal College of Emergency Medicine data shows that one excess death for every 72 patients who wait 8 to 12 hours in ED. SOAS is very, very positive about the future for SWA. We published our roadmap for SWA in January. Its 20 recommendations are a step-by-step guide as to how we can resolve the issues around timely access to emergency surgery for our local community, while at the same time significantly contributing to the fight to reduce waiting lists across Northern Ireland. We like the idea of solving a problem and availing of an opportunity at the same time. The roadmap has received support from right across our community. We need the support of you, our politicians, and the various health bodies across Northern Ireland. We cannot do this alone. This is a David versus Goliath situation. The Trust will present you improved mortality rates called RAMI, Risk Adjusted Mortality Index. We have commissioned an independent statistician to review the RAMI data. As you know, when it comes to data and statistics, it's about what you put in and what you count. It seems clear to us that the sample size is far too small for any health officials to use RAMI in this way as a basis for sweeping hospital changes. As you know, patient and staff experiences, the people behind the numbers, are what we are here to talk about. That's what concerns and motivates us. The messages we want you to remember is it's not about if people live or die. It is also about how they experience health, the waits, the traumatic journeys, it's the uncertainty. It's about long-term harm. It's about delays in EDs, delays in ambulance transfers, and how people recover. The RAMI data that the Trust uses is not an appropriate benchmark when used in this way. CHKS, the company that produces the data, says you need 1,000 deaths. There are only 100 deaths from surgery across the Trust each year. It is not statistically significant. no claims regarding improved outcomes should be made based on that data. But let's not get lost in the weeds of the data here. The numbers we want you to think about are the 93 kilometres between Fermanagh and Altnagelvin, the 10,000 people who have been sent up the road to Altnagelvin, the 45-minute major trauma target that cannot be met, the 2 hours on average that it takes to get from Fermanagh to Altnagelvin, the 300,000 people from Loughairn to Lough who are suffering the unintended consequences of the decision-making by the Western Trust, and the 77,000 people from this area who have submitted consultation responses during the past 3 years. The Trust will talk about the difference between patient experience and patient outcomes. They will say that patient outcomes are measured by RAMI and other clinical data, and they will play down the importance of patient experience. So we need to tell you today that patient experience proves to us, and hopefully to you, that actual patient outcomes are very significantly and seriously adversely affected in ways that are not picked up by the clinical data the Trust will give you. Mark McGuigan was 61 years old when, on the 1st of March this year, he developed gallstone problems at home at Rosslea. As he was over 55 years old, the surgical pathway put in place by the Western Trust meant his ambulance bypassed SWA. It went straight to Altnagelvin ED, where he sat for 3 days, developed sepsis, developed pancreatitis, and eventually developed necrotizing fasciitis. Mark died on the 17th of November, the 3rd year anniversary for when the Western Trust stated that the surgical services were being stood down at SWA. Mark was a friend of this campaign, attended many of our meetings, but he's much more than just a statistic. He is a sign of how dangerous these pathways are to the health of our population. Mark's story will not be reflected in any RAMI stats, as he never actually made it to surgery. He still had his gallstones when he died. The committee will be aware from the recent developmental update that there is still significant work to be done on the implementation of the 10 strong recommendations from the RECWA review. RQIA themselves recognised in a recent meeting with the Health Committee that on the basis of the information they have, that the 2 urgent recommendations have not been met. They indicated that they continue to be very concerned with this. The regulator stated in the report, if these issues persist, it will undoubtedly adversely affect the effectiveness of the clinical pathways and patient experience. SOAS has concerns as to the extent that these recommendations have been implemented so far, and to the extent to which they're capable of actually being fully implemented in the future. Our message is clear. Rural communities deserve equity in healthcare. We need a funded plan to restore emergency surgery at SWA, commission its spare capacity, and create an integrated surgical network. We're asking you, our MLAs, to please press the Health Minister for a clear timeline for reinstating emergency surgery, to consider a call for an independent analysis to assess the impact of the suspension of surgery on the population of the South West region, to support a dedicated rural workforce planning initiative to address systemic issues, to ensure rural health equity is at the heart of your scrutiny work, and finally, to support the case for change. Make SWA a rural area hospital that can benefit the entire Trust region and beyond. This is not just about Fermanagh. It's about the entire Western Trust. It's about fairness, safety, and the integrity of our health system. We cannot allow reform to happen through collapse. We need leadership, we need action, and we need it now. Thank you.
Okay. Thank you very much. It was useful. So I'm just going to go straight on to questions. I mean, we have had the Trust here before. What will be important, certainly for me, but I expect for other MLAs, is patient outcomes. So, I mean, you have stated in your written paper and also today that in terms of the figures that the Trust are using, you don't have faith. Could you just explain exactly why that is? I mean, because these are independent figures.
Yeah. Thank you, Philip, Chairman, and thank you again for asking Save Our Acute Services here today. We do challenge the Western Trust claim of improved patient outcomes following the suspension of surgery. At the Assembly Health Committee in March, the Western Trust stated, effectively the RAMI scores for Altnagelvin have continued to fall to the extent that if you extrapolate the data to look at the mortality rates, you find that due to the change that we have made, every 40 days one patient survives who would not have survived. The Public Health Agency reviewed the RAMI data. We made a number of Freedom of Information requests, and they cautioned the Western Trust about using these figures at all. That was a concern to us. We started to take a look at the information. It was clear from CHKS is the company that produces the RAMI data. They're an independent company. That is true. They're very, very clear, though. They say that indicators that count events such as death suffer from great uncertainty. To be confident of a rate to within 10 percentage points, approximately 1,000 deaths must be included in the data set. That's pretty unequivocal. The deaths during surgery across the Western Trust average at about 100 deaths per year. Okay, this is very significantly short of the 1,000 deaths recommended by CHKS. So based on that information, we commissioned an independent statistician with no connection to Northern Ireland, a fellow of the Royal College of Statisticians who has more than 500 published articles. He worked along with surgical and medical consultants from this area and they analysed the information, and they advised us then that the Western Trust claim of improved outcomes is without statistical basis. That's a bit of a mathematical phrase nearly, okay, but when we asked how can we phrase that in a way that's more understandable, we were told that we could have said that the claims of improvements in patient outcomes based on RAMI cannot be substantiated. And that was pretty unequivocal. The correct analysis has not been done. It's significant to us that the medical director, the chairman, and the chief executive of the Western Trust continue to repeatedly state this claim of improved patient outcomes. And that's, look, it's very difficult for our community to hear these repeated claims. We always find them difficult to understand and to accept. We have been in contact with more than 500 direct families and patients. And both us and these families in particular, they're in no doubt that patient outcomes are significantly affected. This is not just about patient experience, but the actual outcomes, okay? I only have to talk about Mark, okay, who's a very good example, okay? It was very difficult for our community to hear the phrase, and it's during this time, this was in July when the attempt to launch the permanent consultation started. During this time, there was no evidence of any individual patient harm for a single patient. And so it's very upsetting, and I'm trying to be careful in the language that I use to our entire community to constantly hear that actually there's been improved surgical outcomes for patients since the suspension of surgery. We do have an ask. We asked that the Health Committee, call for a correct and comprehensive independent analysis to be done to define precisely the impact that the removal of emergency general surgery has had on the specific patient cohort from Fermanagh and South Tyrone, and to identify that cohort appropriately. And we do ask that. We do intend to contact RQIA as well to update them with our response. We think that the PHE and the PCC may also be interested in that information, but that's the basis on which we challenge the data.
Just so I'm clear, and the trust there will obviously, we will raise this with them, they're on after you. So it's important. So what you're saying is, the data set is so too small to be able to make any judgment. So you're not saying you have any data to suggest outcomes are worse or better, but from a community perspective, you find it hard to believe that what you're being told. But is that a fair assessment?
I think the fair assessment, and this is why we were very, very clear with the statistician to give the language that is appropriate, that the claim of improved outcomes is without statistical basis, The RAMI analysis data should not be used for such a small data set. So what we have to do is ignore the data. Our experience of talking to over 500 patients and their families is that there are significant, there's rather than an improvement in patient outcomes, we would say from our significant conversations that patient outcomes have disimproved for the patient cohort coming up specifically from the SWA catchment area up to Atnagalva. We can't prove that yet, and that's why we're asking, and it's an ask of the committee that perhaps, we brought in an independent statistician, and we're very, very happy to take his information. But we think that for a totally independent view, it would be good if the Assembly Health Committee could take a look at that data. It's a key piece of data for our community, And I can't explain enough the upset that it causes. I could use stronger words than upset, but to individual families who have suffered significant outcomes.
Just moving on to something totally different then, because, it's certainly my view, we're going through a reset, and there's hospital reconfiguration plans out there and consultations, and there's various different aspects of our health service being consulted on. It's my firm view that any change, any change should be planned, and it should be done in co-design with the medical profession, but also the community in which it's involved. You're saying there was 77,000 consultation responses in relation to this specific issue of emergency general surgery withdrawal. So, anything I'm raising with you, I will raise with the trust, and I don't think they'll be surprised. I was at a meeting in Enniskillen last night with engagement this morning with businesses and council representatives, and that there is a sense of perhaps a lack of proper engagement between the trust leadership and the community. How do you think that can be solved so that, I did say this is a wonderful facility. I want to see this hospital doing the maximum amount of medical procedures that it can do. I think that should be co-designed with the local community. So in terms of engagement between the likes of yourselves and the trust and the community and the trust, what would you like to see happening?
We think engagement is very important. I think the first thing to say is that this whole issue of emergency surgery being suspended, it's a hugely upsetting an emotive issue for our entire community. We do our level best to reflect the concerns and the stories of patient staffs and their families. As far as the present relationship with the Western Trust from SOAS is concerned, we'd have to say that it's mainly through email, social media at the moment, but that there is no trust between us at the moment. And that's an unfortunate state of affairs. We did meet with the Trust. We had an engagement meeting on the 10th of March with the Department of Health, and the Trust Chief Executive and the Medical Director were there. We did identify a number of areas of common interest. It was said that the Trust needed additional resources to boost theatre uncommissioned spaces, which is very significant to our campaign. But as far as currently talking to the Trust is concerned, we know that they've proposed what they call a broader people and place-based visioning programme, covering all health and social care matters across Fermanagh and South Tyrone. Now, that's a very broad piece of work that aligns with the Minister's neighbourhood model of care framework. The Chairman has told us it's going to take 5 to 10 years to implement that. Okay? Now, that's a very significant length of time, and that doesn't ally with what we talk about mainly to the Trust, which is about that urgency around getting emergency surgery back. The Minister, when he intervened, and we certainly appreciate his intervention in July in the public consultation, he asked that the Western Trust act quickly to restore confidence and develop a vision plan for SWA, specifically. Now, we are happy to talk to the Trust with regard to that, acting quickly to develop a vision plan for SWA, because that aligns with our objectives. Okay, the Trust determination to speak about their long-term 5 to 10 year plan doesn't align with the urgency that we need to see treated with something. But we are happy to talk to the Trust with regard to the vision plan, and it's very important. One shouldn't stop the other happening, but SOAS don't have to be involved in both. We think it's very important for both to happen.
And just the last question for me. So when we arrived today, we couldn't get a car park space. So I mean, there's an awful lot of things happening. There are lots of people working in this hospital, and there's obviously a lot of procedures and people attending this hospital. So, I mean, how do you think you're navigating? Because I mean, there's always a danger in a campaign like this when you're continually talking about the negatives, that you're actually fulfilling.
It's okay.
It's a self-fulfilling prophecy in terms of talking down the hospital. When I know that's not what you want to do. So I mean, I'm just wondering what's your view on that, and how the people of Fermanagh can promote the good things that are happening in this hospital alongside, obviously, the demand for additional services.
I think, Keith, SWA is significantly, I'd go further, seriously underutilised. A lot of the cars that you'll have seen today are staff. We do know across Northern Ireland that Daisy Hill, the Mater and SWA are the three main sites which are said to have done 18,277 procedures, but there's no breakdown on those. So we have no idea. We would assume that the Mater does the bulk of the work. The Department of Health do say that SWA as an elective centre can perform elective general surgery, gynaecology, breast surgery, paediatric surgery and paediatric dental procedures, but they are by consultants visiting the hospital. We don't have any consultant surgical workforce here for an emergency should it happen. We have had weeks where our elective centre in an entire week has done 18 cases. And these are since the summer of 2025, any of these figures. And our DPU had 5 cases in a week. We've had a week where there were 13 cases in the elective centre and 3 in the DPU. The hospital has not been utilised at all appropriately, and it is such an asset screaming out to be used. I mean, I know that you've been in other hospitals before. This is a unilateral build. It's got everything in it except the determination to make it thrive. We also have to live with a narrative which said that recruitment to this trust was impossible in this area. but there has been no attempt to recruit significantly to this area in any permanent consultant jobs since May 2021, to our knowledge, and that was the last time we were given FOI evidence on it. But I do know that UTV recently looked at the recruitment issue, and predominantly people were looking for locums, short-term jobs, part-time, as and when, and elective surgery. But one of the issues that we feel makes us unsafe is also the fact, I think you were in the elective hub today, I saw it on social media when we came out, but Requia, as part of their 10 recommendations, said that there had to be direct access to a consultant surgeon, not periodically or not whatever day they're there, but there had to be direct access. There isn't, there's phone access. And the Royal College of Surgeons wrote a consultation response when the Trust went out to temporary consultation, and they actually used this phrase in it. They said it's inconceivable that a patient presenting in such a state to SWA, it was referring to trauma, but patients in such a state to SWA would not be seen by an elective surgeon team who is on site and stabilised prior to transfer. But they're not on site. So therefore, you know, our population and our staff are aware of the disadvantages, the overwhelmed ED, and I don't know if it was overwhelmed when you were there, but it's overwhelmed every time I've been there recently. But I do think we represent the staff, and I think the negative narrative is something that has happened through poor management of consultation periods, through lack of recruitment, through those types of short-term job adverts. There's people constantly coming to us talking about not able to get full-time contracts, that they can't get employment, that you can't set down roots if you're given a year of a job. But there are jobs. However, they're being placed at Enniskillen, and at the moment, SWA was funded when it's fully funded. It was funded for 6.5 whole-time equivalent surgeons. Enniskillen had 8.5. There are currently 20 surgeons in Enniskillen and none in SWA. Now that's based, you know, I'm not a doctor, but I do have common sense. That's not fair. You know, it's just not fair. We also, I think, rather than sort of saying we're giving out a negative narrative, we make the staff feel so content to talk to us and so safe. We've never made a staff member identifiable, that they do come to us and they talk about things like in the A&E department, and I'll just choose randoms, but these are from staff members, so therefore the negative thought processes don't prevent the staff from coming to us. Yeah. They're coming to us at great speed. There was a patient recently who had an abdominal rupture and has been assessed by a specialist in ED here. The specialist was on a phone in Enniskillen. That patient could not get transferred to Enniskillen by an IAS ambulance to go to theatre because there was no bed available in Enniskillen, and until that bed is available, that patient can't move. And I think I kind of opened a can of worms that I need to mention. There has been, since Encompass went live in this trust, which was the 8th of May, I think. I'm sure the team will correct me if I'm wrong, but it's on the 8th of May, Encompass should have identified the time for a patient from they arrive at triage in SWA to potentially where they end up needing surgery and going to Enniskillen. There have been 3 memos in the ambulance service in that time warning not to sign on patients in the second ED, but to make it known that you're there to 2 different members of staff in Enniskillen. So there is a rule at the moment where NIAS are not transferring patients until there is a bed available, and those are like hen's teeth. Enniskillen is overwhelmed before we go up there. This is a paramedic speaking. NIAS had the capacity and resources to respond to calls in the community, given the local landscape of the health service prior to the suspension of EGS. Since its suspension, more ambulances are having to travel more miles with sick patients to wait at the back of a queue in Enniskillen. So from the nursing point of view, there are patients constantly queued up one example, there was a man who waited 77 hours. He went in with a significantly bad foot situation. I don't know if it's post-surgery, but as he remained in the department for those 77 hours, the foot became less and less viable. That man had more significant problems, but the orthopaedic consultant had to bypass him twice because there were people already in a queue in Enniskillen. So therefore, we're always going to be back at the queue here, metaphorically and physically. It's just a fact.
Okay. Thank you very much.
Sorry, big long answer. Sorry.
I'm just going to allow other members on here. Colin?
Thank you very much, Chair. And look, this is certainly not meant, by the way, initially in a condescending manner, but can I thank you for the work that you're doing, because I did a bit of studying of community development and community activism, and I think what you have done is, for by the issue and the people in the room and what we're doing, I think actually the model that you've taken, where you engage with people, you interrogate the issue, and you try to shake the power that is there for decision. I think that is actually admirable. I think you're one of the better examples that there has been ever in terms of doing that. And one of the things is that quite often as politicians we get people come to us and they complain about something, and we get frustrated too whenever we hear what it is that they're complaining about, and it's almost like we have to say, but what do you want instead? Like, what have you got, what's your alternative? Because otherwise we're just going to go and complain about nothing. And then we have this.
Yep.
So can you talk us through the development of this, maybe give us some of the highlights of it, and maybe where you feel some of the issues of this could really could stand good stead in terms of being able to be offered as an alternative?
Okay. Do you want to start, Karen, and just do the local? Are you sure? Okay. Helen had a line, actually, during the introduction when she said, we like the idea of solving a problem, okay, and availing of an opportunity at the same time. Okay, and that notion that, to our mind, we do have a problem, okay, with regard to the lack of emergency surgery here, but there's a genuine opportunity in this hospital. You have travelled around the hospital today, okay, so you've seen the astonishing build that it is, okay. I don't know if you've seen the uncommissioned rooms and the uncommissioned theatres, but apart from the fact that it's an astonishing build, there's all that available capacity there. So what we did as part of the roadmap, which we launched in January, is that we actually went back to the original business case for when this hospital was built first. And it was really important, okay, because that gave us figures that we could see what the plan was for here. The hospital's running at about half the level of activity that was in the original business case. So that should really tell us something. That this idea of having physical hospital infrastructure available in the region, in particular to help to drive down waiting lists, should be something that's very attractive to everyone across health, and certainly the health committee, okay? And it's very important to us. This is a really positive document, okay? We think it's very well researched. It's been out since January. We haven't been challenged significantly on any of the facts in it. But the key is that it says, how can we solve the problem of getting emergency surgery and build on the opportunity of the capacity that's in the hospital? And I have to say the incredible staff that are in here as well. Okay, so it looks at an accelerated elective care work coming into the hospital, okay, across a number of key specialities that can be identified. Okay, that bringing a level of surgical activity into the hospital. Okay, complemented by cross-border surgical, elective and emergency activity that will serve to make the hospital much more attractive for consultant surgeons to come to be based in. Okay, and that is the core of the roadmap, but it's a very positive roadmap, and it sees a really bright future for SWA, which we think is very important.
And have you had an opportunity to discuss this with the Trust, or to be able to maybe even with the department in terms of some of the wider departmental responsibilities or responses that would need to be to it?
Yeah. We met with the department on the 10th of March and we formally presented the roadmap to them, and Neil and Brendan Lavery were at the meeting as well. Okay. And I have to say, it was a very useful meeting. There was a lot of common areas of interest identified. Okay. And there is an acknowledgement, certainly with regard to the elective area, that there's lots of opportunities here. I think the part of the argument that we want to make as a campaign is that we need to look at the emergency surgery as well. That's that local element, is us getting the emergency surgery.
Just secondly then, when I woke up this morning I was thinking about being grumpy. And the reason I was thinking about grumpy was I thought to myself, I'm going to have to drive home later and it's going to take me 2.5 hours. And I thought to myself, that's a bit rich, because I remember proposing that we actually come here today, and I thought, well, there's not much point in being grumpy about it at this stage. But then whenever actually it sunk in a wee bit more, I was thinking about Mark McGuigan, and I was wondering, we do hear a lot about time scales, and we hear about being able to be, there's time to get here, then there's been treated here, or there's time to bypass here. Can you just give us maybe a wee bit more detail about those timings? Because I will probably be home quicker than if you were going from Garrison up to Delta-Gelvin, and I will probably be right across to the east coast of County Down in that time. So maybe just to give us a little bit of a sense about the timings.
Thank you for that, that question, Helen. I suppose the central tenet for us to take this forward through the elective process, etc., has to be the restoration of emergency surgery. And we have two key areas. We have emergency surgery and we have trauma care. Geographically, our demographic determinants put that as a massive challenge for us as a community, a rural community. What happens is, and what is set out, and maybe to put it in context, some of the documentation and the process that we use to deliver services is utilising information and process that's used in Britain that has a different demographic. And in relation to that, distance from hospital, from home to hospital in the UK, 95% of the population in the UK are within 12 miles of an emergency department. And that's broken down further and averaged out, most people are within 4.7 miles in urban areas of their hospitals, and the maximum distances is about 10.9 miles for the rural population. Now that's exceptionally significant for us for a variety of reasons. What has happened with the removal of emergency general surgery, it has compromised the integrity of our major trauma network. Our major trauma network is the centre is Royal Victorian Hospital, but it is supported by 8 regional area hospitals that can stabilise patients and then transfer patients in a more stable condition to the Royal. A quarter of those have been removed as a result of emergency general surgery closures in hospitals. Why is that important? It's really important. It's a significant statistic. If you encounter a major trauma episode, if you can get to a major trauma centre within 45 minutes, your survival rates increase by 20 to 25%. That's a very significant improvement in a health outcome. In relation to surgery, emergency surgery, the recommendations are 60 minutes. But what is often missed as part of this conversation that we have with people is that when the South West Acute Hospital was first developed, there were challenges, absolutely, and rightly so, as to the location and how it would serve the population. But what happened was it went to judicial review ultimately in 2004, and that's where it was established that it was necessary to have the hospital here in order to comply with those recommendations. The fact that we don't make those, we are now seriously challenged. We talk about standards in care. We cannot meet those standards, or we will never meet those standards with the removal of emergency general surgery to what would be considered surgical and major trauma international guidelines. If we're looking at our evidence base, that's what it states. These are international guidelines, accepted practice. In addition to that, we really don't understand, since the removal of emergency surgery, there's a process in emergency care which identifies and records situations that happen and the care patients receive through their patient care journey. It's called TARN. That, unfortunately, became defunct in last year, or a couple of years ago, in relation to a cyber breakdown. However, they have reinstituted that and they've got it up and running again. But we can't see any data in relation to that being done here. We don't see any of the data. The last recorded data in relation to this service was that I have seen is 2018, 2019. So we're blindly going to go into a reconfiguration of networks of hospitals where we have no data on the emergency cover for a rural population in Fermanagh that can impact 80,000 people. So the travel times are very relevant, and I think when we put it in context and we look at what service provision is given in Britain and what's acknowledged as best practice, I would have to travel 60 miles for access to emergency care. So I think that's clearly outlines, hopefully, Colin, your question, and makes it clear.
Can I just give one tiny clarification, or maybe two actually? The trauma data here has only been collected in the last 2.5 years manually, one man in each hospital, but there has been no data compiled for analysis, no interrogation, so therefore there would be no way to tell if, for the sake of argument, playing devil's advocate, maybe things are brilliant here, maybe trauma outcomes are 10 times better than they were when we had surgeons in our hospital. I don't think they would be, but it's not okay to reconfigure services without checking out the exact level of damage or improvement in all cases in the region. There is no data being collated at the minute. And just before you get grumpy, from Rosslea to Enniskillen, where Mark lived, takes longer than if you went to Belfast and you went to the new bus station and you said, I'm going to Beaumont Hospital in Dublin.
And Colin thankfully woke up happy this morning because he normally wakes up grumpy. But I get shouted at the last meeting for allowing things to go on too long. So I do want to keep check in today's meeting. So I'm going to, now selfishly that I give myself enough time, I'm going to ask all members to be concise, and if we can be concise moving forward. You're happy, Colin?
Yes.
Okay. Yourself?
Yep. Thank you very much, Mr. Chairman. Look, I really welcome the opportunity today to come and see the facilities here at the SWA. It's my first visit, and I have to say I'm hugely surprised. And I think you have to actually see it to appreciate the size of the site and the opportunities that are there to be grasped. But a building like this, with all its modern theatres and the ensuite patient facilities, it should be playing really a major role, not just locally here, but regionally. So I'm glad that some of the unused theatre capacity has come online recently. But what are the other opportunities do you feel that SWA has that still need to be tapped into?
I think, Alan, some of the opportunities that have been missed here, SWA should be a centre of excellence. SWA should always have had the available resources and savvy to just decide. We retained stroke services here because they were batting way above their standard. We had standards which were among the top in the UK. We had initiatives such as Our Hearts, Our Minds, which was a preventative heart programme, which was unique to this hospital. These are all in the last 10 years. If we had embraced those and built around them more and capitalised on them, again, I feel we would have recruited, we'd have gained much more attention. We also have missed out, in my opinion, we've missed out on cross-border funds when Northern Ireland has none, whether it's CAUT or SEUPB, because one of the most successful things that those European funds have provided are the North West Cancer Centre in Enniskillen area, and the paediatric cardiology, which obviously takes its way down to from wherever to Dublin, and we're living here in an area where we easily should be providing something there. And I know that the Chief Executive is here, and I'm sure he can say more than I can on CAUT, but I did read at one stage where he commented on the incredible work in the North West Cancer Centre, which we all do applaud. But he did then mention that it was to his deep regret that he had not managed to get any traction similarly in the southern sector for over a decade. And I didn't think that was a great finish to the sentence, to be honest. So I think the hospital should be thriving, Alan. It should be playing a much bigger part in the elective framework. It's an asset, it's not a problem. It really should be an asset.
Yeah, I did notice when I came in, just, there was a lack of hustle and bustle about the
Yes.
place, and
Yeah.
you'd see when you go into one of the big
That's it.
hospitals in Belfast. But like yourselves, I welcomed the Minister's intervention over the summer when he directed the Trust to revisit the flawed consultation process. And I saw the Trust's apology a number of weeks ago, and it was absolutely, it did need to happen. I know that there has been a recent unsuccessful attempt to have a meeting with the senior team here at the Trust and yourselves. But have you had any engagement at all with the Trust yet since March, even at a lower level regarding the vision work?
I think it's very difficult to describe the relationship. We've gone through a previous consultation structure where people in this area felt very badly dealt with. And I think had any of you been there, you'd have felt the same thing. It is really unfortunate, the position of trust and mistrust. And again, when the Trust brought out the permanent consultation on the biggest bank holiday weekend that Northern Ireland has, and when Stormont was sitting down, it is so hard for people to have confidence in decision making that's sprung across you. However, we welcomed Mr. Nesbitt's intervention. We also noted during the week that the CMO actually has offered as well to communicate at whatever level. So we will never say never, but we will not be entering into discussions that are meandering on for 5 or 10 years about the Pathfinder type, the community model of care, the shift left. I can't remember the newest version of the name now. I'm sorry, I really can't.
Community model care is right.
Neighbourhood care model. Thank you. But But if it's about the urgent response that the Minister did ask for, to act urgently to rebuild confidence, that's the part that we asked questions and wanted to meet on, and we were more than willing to do that.
Well, thank you for what you do.
No,
Yeah,
thank
thank
you,
you,
Alan.
Thanks. Alan, second, Alan. Robinson.
Thank you, Chair. Thank you, Helen, Karen, Jimmy. Solidarity from the good people of the North Coast who face a similar type battle to try to preserve and save their emergency general surgery. My deepest apologies for not being there today in person. There is a sense of irony me not being there today, but I have an event tonight in the North Coast, Northwest area, and it would be too difficult and too challenging to try to make it in time. And the irony in that is that if I, as someone going to just an event, how challenging is it then for people who are in an emergency vehicle having to try to make it from Fermanagh up to Galvin.
Yep.
But can I just ask a couple of questions, just so that I understand this better? The Minister quite rightly say that he asked the Trust to act quickly. I think that's very definitive language. However, you go on to say there that for this Pathfinder project, it could be 5 to 10 years in the making. Can you just explain why so long? Because obviously the people of Fermanagh don't have 5 to 10 years. They want a decision on this as quickly as possible. So could you just explain that one so that I better understand that?
I will quickly, I think just two parts to the answer. The first is that I think the 5 to 10 years was actually put into context with the discussion that you had last week with the Minister and the departmental officials, where we heard mention of 10 to 15 years and then even 30 years, about different elements of what might be the new neighbourhood model of care. That's why we identify it as something totally different. Okay, the actual statement from the Minister to act quickly to restore confidence, which we think is a very important phrase, because acting quickly is a key part of restoring confidence, and to develop a vision plan for SWA. It's a totally different piece of work from working on the neighbourhood model of care, and it should be a short, concise, quick piece of work where we can genuinely develop that vision plan for SWA that we think we can contribute to.
I think also just to mention that I think it was the non-executive chair, Mr. Frawley, who mentioned it in a letter to us that it's 5 to 10 year process.
Yep.
So it kind of makes it much less likely to save lives in Fermanagh.
Can I ask Helen, can you tell us a little more on the 10 core recommendations from RQIA? To what extent do you believe they have been implemented?
Here we go. Thanks, Alan. First of all, the first 2 of them, the double ED is still happening. I don't mind, there will be corrections to that, but I'll stand over that. That is the truth. The double ED is happening. It doesn't matter if it's happening to 2 people a week or 10 people a week, but it is happening, and it is actually, according to the Trust Zone data, it is happening considerably more often than 2.5 times a week or 2 per week. The lack of sufficient commissioned ambulance capacity has been further depleted by that, the issue that the ambulance are now standing over, where they won't lift a patient unless there's a bed to go to. So I know that those were the first 2 considered urgent by RQIA, and the words that the RQIA team used when they were with you guys in March was that if these 2 persist, it will undoubtedly adversely affect the effectiveness of the clinical pathways and patient experience. And I think the only other one that there's too many in 10, but the other one is the elective centre. It's the fact that Requia stated we needed direct access to a consultant surgeon. That's not by phone 93 kilometres away. It's not that way.
Could I just then ask a couple of follow-up questions then, Helen, beyond that? Recommendation 3 used the word should.
Yeah.
And it used that twice. I know I've raised this committee in the past. How do you define the word should?
I don't. How do I describe it? As porous as anything. It's not definitive enough at all. It's really not definitive at all. If we are to have the same likelihood to survive with our postcode, I think a few of those open words should be a bit more defined, quite a bit more defined. I'm not impressed with those kind of open words either, Alan, but at the end of the day, I don't want to be falling out with anybody else.
Helen, you also, in your response there to me, you made reference to staff and consultant surgeons. Given that it was workforce issues that have brought us to here today, how does your group and you feel, the best course of action to try to recruit consultant surgeons to SWA?
Thanks, Alan. It's the recruitment of surgeons and other associated staff is a key element of our roadmap, and we do go through it in a good bit of detail. Page 17 for any geeks out there that want to take a look at it, okay? But waiting lists have been branded as a national shame by the newly installed regional elective care director. Okay, SWA should and could be playing a really significant part in challenging them down. We can have, in terms of getting consultants to come to work here, we have in the roadmap targeted incentives and working conditions can be developed to attract and retain surgeons, and this has worked elsewhere. There's no reason why it shouldn't work here. Developing a genuine region-wide integrated surgical network, as proposed in the roadmap again, will facilitate the arrival of consultant surgeons to SWA. Okay. Agreeing a comprehensive job plan for surgeons that includes significant sessional work in OMA, and this is a key part of the roadmap. OMA is closer to SWA than it is to Athnagelvin. It's got 3 day procedure units there's an awful lot of work going on in. It's our opinion that those consultants, we could have consultants based in SWA, and that the sessional work in OMA would provide a key base for the high level of activity that we need to have going on here, and that's a key part of the roadmap. Bringing appropriate specialities and volumes of elective work coming in here again will complement that. And I'd just say, most importantly, okay, and this is we do believe this, a sincere willingness and commitment across all the management levels of the Western Trust can lead to a strong consultant workforce being based here on a full-time basis.
Ellen, Jimmy and Karen, good luck in your campaign.
Thank you, Alan.
Thank you.
Danny?
Thank you, Chair. A couple of the questions I was going to ask Alan has already got in front of me. Well done, Alan. This, I would agree with the other members that saying this is a fantastic build. When we arrived here, it's huge. I've worked in a lot of hospitals across Northern Ireland previously, and this really is a shining example of a fantastic, up-to-date hospital. It looked very busy to me. Car park full. You know, we were taken through various wards and departments, and you know there did seem to be a lot of activity ongoing. So it's clearly there's a lot going on, which is good.
Can I ask, sorry, this is probably breaching all sorts of rules.
Right.
Were you allowed to wander around on your own?
I
don't know.
No,
All right,
no.
sorry, just
We were taken through. But we have asked to see theatres and wards that that haven't been commissioned, and I think we were in a theatre. And we were shown that as well. So
super, yeah.
Thank you.
Yeah, no, a very, very high standard. Clearly, Fermanagh has a very different geography to the rest of the country. There's a lot of rurality here, so you know, there is different considerations. Two questions. The first one just relates to the designation in the roadmap. That's, I think it's recommendation 20, that SWA is categorised as a rural area hospital. Can you tell me where that came from and what that would mean?
We certainly can. The rural argument is one that we don't do very well in Northern Ireland generally. Okay, I know that anyone that's from Causeway and Daisy Hill will feel the same pain to a degree. We will say that it's even more significant here. Okay, it's 93 kilometres on average for the people of Fermanagh to get to Enniskillen. Now that is a long distance, and it's just too far. So when we took a look at the hospitals. Reconfiguration hospitals, creating a network for better outcomes, I think is the full text of it. When we looked at the document, it suggested classifying SWA and Daisy Hill and Causeway as what's called a general hospital. Now, we felt that didn't apply. Two quick lines from the definition of a general hospital. Okay, I can find it here. Sorry. Not available at the moment. Okay, it's 15. Yeah, no, I have it here. No, I have it here. Is why couldn't these three hospitals be area hospitals like the other hospitals, okay, just on a smaller scale? It simply says they cannot just be small area hospitals. The resources do not exist to perpetuate this. So it's a financial decision at its core, okay? Now, what's very important, okay, is that we didn't feel that SWA needed to be a full area hospital. And it shouldn't need to be a full area hospital. But what it should have is those key essential services needed within it to support full emergency surgical and medical ongoing sustainable care. So we didn't think that a general hospital was suitable, and we didn't also feel that an area hospital was suitable. So we came up with our own definition, and that's what's in the roadmap. And it's a very specific definition written in the tone of the consultation that should lead to those key emergency, surgical and acute services being based here in the hospital. So very interesting, but 28,494 people signed individual consultation responses, agreeing with us when we said that SWA should be designated with this new designation, rural area hospital, and that was 94% of the people that responded to the Department of Health consultation. So we feel there's a very strong case behind it as well.
Thank you. One of your other figures that jumped out at me when I was reading it was the 92 unused beds. What does that relate to? What is that?
The hospital has 92 uncommissioned beds. That was one of the items actually that I remember in the discussion on the 10th of May, because Neil, the chief exec, had mentioned that was a topic that he brings up regularly with the Department of Health. But there are 92 uncommissioned beds in SWA, and that's all I know.
Absolutely.
Okay. No problem. Thank you. Thank you, Chair.
Thanks. Dan?
Thank you, Chair. And again, like Alan, apologies, but I haven't been able to get with you today. Can I just ask, it's really a question around the building up of staff and so on. When we all heard that they were now going to use the 2 uncommissioned theatres, and I think we had high hopes that this would lead to an investment in staff and an expansion of theatre activity. But it transpires, as I understand it now, that this is simply the independent sector in Musgrave coming in with their nurses, their doctors, everyone using the theatres and going out again. Have you heard anything further about whether or not this might lead to the build-up of services, or is this just a one-off, short-term thing that has been announced?
We did welcome the announcement recently that there was, I think, 600 procedures planned as part of the rollout of the elective care framework for the current year. That was definitely good news. To our knowledge, that was a standalone piece of work, but that we know that there's conversations going on with the independent sector to agree long-term contracts, which we do have a concern about, because it's our preference that work in the theatres here be done by NHS staff, okay, and that it's free at the point of need. Now, we did welcome the work, but we understand the use of the independent sector, okay, but that needs to be coupled to those long-term NHS efforts to bolster SWA's surgical and medical capacity. It's in the elective care framework, which obviously is only a single year because you haven't got the multi-year budget agreed yet, but certainly for the single year, and there's some longer-term aspirations in it. One of them is that, and it's very important, is that there's an undertaking to build recurrent HSC capacity and to recruit staff to newly created posts to reduce the dependence on the independent sector. Now, we think that's very important. We have a concern that that mightn't be focused on appropriately, because when the independent sector come in, that might take the emphasis away from that. But we think it's something certainly that the committee should look at, ensuring that this intention in the elective care framework to build local HSC capacity to do this work is very important. And they can work alongside the independent sector until such time as they're well established. And then the key of our roadmap is local NHS staff working in local theatres, doing work for people from the entire area.
Sorry, Jimmy, can I just add to that, Diane? I'm sorry, just while we did welcome the story, it's 12 procedures a week that we're talking about, the knees and hips. That actual group and the same surgeries have been here before. This is not new. It has recurred on many other occasions. But there was a letter in one of the local papers recently, or an article rather. I think it was Teresa Malloy, but I could be wrong, who had said that due to winter pressures, that it was likely that elective procedures would be less, and from what they are actually even now, which for our staff, for our hospital, it's each of those statements become very frightening issues. It is depleted enough, and to think it could be doing less during this winter is quite frightening. And as you said, Alan, the space downstairs, the calibre of the area, it should be bustling. It should be running. That's it.
Could I just say as well, in relation to that, Diane, in relation to the independent sector, theatre staff are very skilled personnel, and it takes time to develop those skills and consolidate their knowledge. So while the independent sector is probably a useful adjunct currently, it will take time to build those. We need to start now, and we need to make sure that this is that element of security. Where you have independent sectors coming in to do surgery, you will get a reluctance on potentially consultants that want to base themselves here would be reluctant to engage in that process. They want regular teams working with them. Regular teams produce good outcomes. And from the regional point of view, the job creation and sustainability and the recruitment and retention are all linked into that piece. So it is quite complex, but it's really important that we establish our own personnel delivering a high standard of care that we have done before. The one thing I think we haven't really touched on today is that we had a thriving emergency surgery department up until recently. And if you equate it to the hospital that we have here, it is most unusual that any hospital that I have seen to date with the facilities and the capabilities here have had their emergency surgery removed. So that's really important. Thank you.
Can I say thank you? I mean, I absolutely agree with you. And I know that many of you know my background. You will know that I know the SWA very well. I've visited family in it many, many times. It is a fabulous facility that is hugely, hugely underused and underutilised. But if we are to build up and to utilise the facility, we can't do it without staff. And we need an investment in long-term recruitment, as you say, and we need to build up our health service capacity in relation to staff. So, I mean, I mention it because I think that the emergency surgery issue is really, really important. But for me as well, building up that cohort of staff that support emergency surgery, not just consultants, is also hugely important as well. And I do think that the announcement about the elective procedures, well, I welcome them. I mean, like yourselves, I welcome them. Anyone who's knee or hip pain will be delighted to have their surgery done. As I understand it, it's mostly day procedures that are being done. But they'll be delighted to have it done in a facility like the SWA. So yes, it is good as far as it goes. But it's very temporary and it's not an answer. And I thought maybe we were kind of being led in a way that maybe didn't help us to see the full picture. I'll maybe leave it at that in as polite a way as I can. But thank you for all that you do. I intend to pursue some of these questions with the Trust when we see them.
I just wondered, and it might be something that you could maybe bring up with the Trust. We are made aware, as I've said to you, there's a huge amount of trust placed in us at this stage by staff. There are a lot of staff who are not on full-time contracts and would love full-time contracts. There's a lot of part-time contracts. There are people who are applying for their own jobs with regularity. And there are people who we get contacting us, one even this week did, dying to get in to help out with winter pressure, but just not an option. There's not going to be. That was a nursing position, I should have said too. So it is, recruitment has to be permanent for any nurse to be able to settle in an area. It has to be completely permanent.
Thank you. Linda?
Thank you, Chair, and thank you to all three of you for your presentation. It's more than a question, it's more of a point, Chair, rather than a question. And to yourself, I would like to see the statistics around that last point that Helen made around the permanent contracts for staff, because that is true. There's absolutely no way that staff are going to stay somewhere that they're not secure, that they don't have a secured post. And that will lead to, as we've said, it's actually that is what will lead to the winding down of services within the hospital. I also think that we need to get some statistics around, precise statistics around what is going on in the hospital. I would like to understand why the elective surgery would be being stepped down over the winter pressure months. I mean, I think it's probably down to the availability of surgeons, but I think we need to know that. And is it because the SWA has been used more for patients who just need to be hospitalised, who are very ill? So we need to understand all of that. I think that it's really important that we get information around that.
It's not a question.
Sorry, just the last thing that I just wanted to ask is, and I don't know if it's for us to ask the Minister, is around the commissioning of those 92 beds that Helen referred to. So if there's 92 beds uncommissioned, is that down to the trust or is it down to SPPG? We need to understand, have bids been put in for those beds to be commissioned for a specific reason, and those have been turned down? Because I would be very concerned if I thought that we talk constantly about having services in all of the hospitals and needing every single hospital, but where there's a hospital with beds available, we're thinking it's away out in Fermanagh, not going to use that. If that's the approach from the department officials, I would be very, very concerned about that, because that's a bigger issue than the trust.
Yeah. Can I just say, just very, very quickly on that, Linda, and thank you very much, that from the point of view of when we met with the department and with the Western Trust on the 10th of March, Neil Guckian, the Chief Executive of the Western Trust, did point out, and Helen has said it already, that he's repeatedly asking the department to free up these beds, that they need to be commissioned. Okay, so now, obviously it's a question that you can ask the Chief Executive yourself, but it would seem that we should be focused on the SPPG with regard to trying to get those beds commissioned
and staffed.
Yeah, I think we need to write to the department on that one.
Yep.
Chair.
Okay.
Thank you for that, Jim. Appreciate it.
Okay.
Thank you.
Thanks, Linda. Thank you very much. That's been very useful, and we appreciate you giving up your afternoon to come before us and take our questions.
Thanks very much.
We'd just like to close by saying thank you again. We know that it's a long way to come down, and there's been a couple of mentions of distance, okay? And our campaign is not just about distance, but it's also about the opportunity that's in SWA, and having walked around it,
Absolutely.
we trust that you'll have a much deeper understanding of that now.
Can I also say
thank you very
that
much.
if there are further questions that are going to be asked about any of the material we've referenced, we can happily share that with you.
Thank you very much.
Thank you.
Thanks, everybody. Thank you.
Thank you.
Safe trip home.
I'll not be grumpy.
Okay, members, we're just going to move on then to item number 6 on our agenda. So that's an oral briefing, an overview of services within the Western Health and Social Care Trust. So can I refer members to our papers at tab 6, page 14 of the main pack. Yeah, page 14. And just going to welcome to the table, we've got Neil Guckian, Chief Executive of the Trust, Dr. Tom Frawley, Chairperson of the Trust, Dr. Brendan Lavery, Medical Director, and then Theresa Malloy, Director of Planning, Performance and Corporate Services. So you're all very welcome. And you were all name checking that previous presentation, so you can expect. Yeah, I mean you'll have a good sense of the kind of questions that we're going to ask. But I'm going to hand over to yourselves just in the first instance, if you just want to give some opening remarks before we take questions.
Thank you, Chair. If, with your permission, I would maybe just like to do an introduction and then ask Neil Guckian to go into the detail that would describe the overall activity and operational arrangements of the Trust, pending then the questions that you may wish to pose to us. So, Chair, I want to begin, of course, by welcoming the Health Committee to the South West Hospital. You will have seen from your tour that this is a busy hospital, committed to meeting the needs of the local population. It has a Type 1 ED with a full consultant staffing, an intensive care unit, maternity services, paediatrics, and a range of acute medical specialties. It also has an elective overnight stay centre, and alongside our day procedure unit in Noma, it provides surgery for patients outside the Western Trust. At the outset, I want to acknowledge how concerned people have been about the changed pathways for inpatient emergency general surgery, which transferred to Altnagelvin, as you know, in December 2022. We could no longer sustain that service with no substantive consultants to staff the rota. However, today, many people continue to have their surgery on this site, and there are more patients being treated across more specialties than in previous years. I pay tribute to all the staff within this excellent hospital. You'll have witnessed their commitment and compassion today and every day. We will expand on the impact of revised pathways for emergency general surgery in Neil's presentation. I want to briefly speak to the geographical, economic and demographic profile of the Western Trust population. A key priority for everyone in health and social care leadership, and I'm sure for this committee, must be to reduce the significant health inequalities which exist across health status in Northern Ireland. Our geography in the West presents challenges, with a significant distance from the northern boundary of the Trust to its southern boundary, and significantly therefore between our two acute hospital sites. The distance involved compounded by an underinvestment in the road network and the complete failure to make any progress on the A5 roadway. The Trust also borders on several counties in the Republic of Ireland, which brings opportunities for partnership working. But you must also understand brings additional challenges for this Trust to recruit and retain staff in what has become a very competitive labour market. We have lost a significant number of staff to the Republic of Ireland. These are very, very scarce skills and resources, and they are experienced people. Our Trust has some of the highest poverty and deprivation levels in this region, creating high levels of need and demand for care. The committee will know that the two council areas in Northern Ireland, Derry City and Strabane and Belfast, have a greater number of areas assessed as being deprived than any of the other 374 local authorities in England, Scotland or Wales, and significantly the rest of Northern Ireland. Derry City and Strabane is a place where we see multiple dimensions of deprivation across the domains of income, employment, and health deprivation and disability. 5 of the 10 most deprived areas in Northern Ireland are within that council's boundary. East, Creva 2, Strand 1, the Diamond, and Cregan Centre. Significantly, however, Fermanagh, where we experience obviously similar difficulties in terms of particularly of rurality, there are major issues in areas like the domain of technology, that the issues there are significantly more medically based specialties than they are surgically driven requirements. There is a different but nonetheless concerning picture, as I've said, in Fermanagh and Omagh, which shows that poor physical and online access domain is more pronounced in this rural geography. 5 of the 10 most deprived areas of access to services in Northern Ireland are in the council area Belcoo and Garrison, Rosslea, Trillick, 6 Mile Cross and Owen Killew. The health status of our population differs quite significantly between the northern and the southern sectors. According to the 2025 Northern Ireland Inequities Quality produced by the DOH and the Northern Ireland Statistics and Research Agency, that shows that across a range of 32 health outcome indicators, in our northern sector, the population has 17 health outcomes that are worse than the Northern Ireland average and 15 which are similar to it. By contrast, the southern sector, there are 8 health outcome indicators that are better than the Northern Ireland average and 23 on a par with it, and only 1 which is worse than the Northern Ireland average. This data shows that we have pockets of need and areas of particular health inequality in the West, some of the worst in the United Kingdom. A uniform approach to addressing need and reducing health inequalities will not work for our population, and a targeted approach is needed, and to that end it is urgent that the capitation formula that informs the calculation of the financial allocation for each trust area includes within it a weighting to address deprivation. Finally, before I stop, if I may, and you're probably glad to hear I'm about to stop, let me make the point that I never said that it would take 10 years to develop a vision. The simple statement I made was that the vision would inform decisions that we would make for the next 10 years. And anyone who believes that we should make these types of complex, expensive decisions without that careful consideration in an environment where we're told already we are £400 million short of what we need to run these services next year, I think it cannot be described as being realistic, Chairman, without being offensive to anybody. The committee has invited us to present on the trust-wide issues. I will now pass over to Neil, who will continue the presentation.
Good afternoon. I want to outline some of the Trust's key challenges, but I will give balance by closing with some of the key big successes that this Trust has had in recent times. But Health and Social Care and the Western Trust are faced with unprecedented pressures, with significant gaps between our commissioned capacity and the presenting demand for access across our services. Increased demand will be linked to deprivation and also to demographic changes, which means we are caring for older, sicker and more complex patients in our hospitals and in the community, but also that we have higher numbers of children in need and informal care, poorer mental health, reflective of the health status of our population. I want to start with our significant challenges within mental health services. Mental health services are experiencing extremely high levels of need, with all areas of our service experiencing more people needing support as well as more complex needs. We have conducted a deep dive of our review of adult mental health services with a number of ways to improve patient experience identified. However, more funding is required to support these to get the full benefit from our improvements. There's also work needed improving how different parts of our system work together, making it easier for people to navigate. More long-term funding is required if we are to properly transform our mental health provision. The sickest of our mental health patients are cared for in our acute mental health hospitals in Derry and Omagh. We are commissioned for 56 inpatient beds across the Trust to care for people, including 10 psychiatric intensive care unit beds. We often operate and usually operate at over 120% capacity, which puts pressure on staff and is not the standard of care provision we would wish for our very vulnerable patients. In our mental health services, we are heavily reliant on agency locum doctors and have struggled to recruit a single consultant despite agreement from the Department of Health for a recruitment and retention premium of 20% for a number of specialist roles. Our psychiatry funded staffing levels do not reflect the level of need linked to the deprivation in the West. The Department of Health's report on consultant and SAS doctor workforce as at May 2023 showed our consultant psychiatrist numbers as 5.6 per 100,000 of the population, with the average in Northern Ireland being 10.7 per 100,000. So we have, when you take West out of the figures, we have less than 50% of the psychiatrists of the rest of Northern Ireland. Whilst the challenges are at the most extreme in psychiatry, the Trust has experienced staffing challenges in a range of specialties, and I will cover them shortly. But mental health is not all about beds and doctors. Much of our care is given in the community and through crisis support. However, the level of need and the level of gaps in our medical workforce to treat that need do create risk. Investment across beds, medical staffing and community crisis services is required. Turning on to medical staffing, I have highlighted to the committee before about the disproportionately low level of medical staffing in some specialties in the West and the consequent reliance on agency locum staff. The Western Trust continues to face significant medical workforce pressures, with 104 active medical and dental vacancies representing around 13% of our funded establishment. Most sustained challenges are in psychiatry, ENT, radiology, paediatrics, obstetrics and gynecology at Altnagalvin, on uro-oncology and oral maxillofacial services. These pressures are reinforced by long-standing issues with medical trainee supply, including a mismatch between the number and type of NIMDA doctors in training and service need for those trainees, a low number of senior trainees in key areas, and rising numbers of less than full-time in trainees. All this creates an ongoing rota fragility, higher dependence on locums and associated costs, and impacts on waiting times, staff well-being and service resilience. ENT remains an area where we have particular concern, though we continue to maintain safe services. We currently have one substantive consultant supported by a locum consultant, an international appointee and temporary agency cover. While this provides day-to-day stability, it does limit the depth of the rota and has contributed to the loss of allocated trainees. Recruitment efforts are ongoing through local, regional and international routes, and we will continue to build on these to strengthen the service. Other specialties, including paediatrics, radiology and oral max fax, continue to depend heavily on locums and retired consultants returning to practice to maintain continuity. Radiology in the West receives disproportionately low numbers of senior trainees from Nimnata, relies heavily on internationally recruited doctors and faces increasing competition from GB trusts offering more attractive terms. In obstetrics and gynecology, we are seeing differing pictures across our sites. South West Acute Hospital now has a fully staffed consultant rota, which has significantly improved the stability here. And indeed, we're optimistic and soon to increase it beyond our funded establishment. Altnagovan continues to face real difficulty attracting candidates because we operate a combined obstetrics and gynecology rota. This differs from the separated rotas available in other trusts and is a barrier for applicants seeking subspecialist focus or a more manageable on-call pattern. So what are we doing about our medical staffing issue? Across all specialties, we are pushing ahead with stabilisation measures, including significant investment in international medical recruitment, including a bespoke campaign to India, talent pipeline and development, targeted attendance at national and international psychiatry events, the development of specialist doctor roles, the use of physician associates and clinical fellows, and increased flexibility through retire and return and part-time options. However, to secure long-term sustainability, we do need regional action, a strategic review of future trainee supply by specialty, more equitable Nimnata allocations, both in number and seniority, a fairer distribution of new to Northern Ireland doctors across trusts, and ensure Northern Ireland pay and conditions are aligned with GB to enhance competitiveness with other UK regions and internationally for scarce medical talent. In relation to social care, both our acute hospitals have high levels of patients who are medically fit but are delayed in being discharged from our hospitals. The level of commissioned nursing home places is much lower in the West than all other trusts. We have over 500 less nursing home beds than any other trust in Northern Ireland. We struggle to source domiciliary care in some rural areas in our southern sector, delaying people who require packages of care, safe discharge, and this has had a major impact on the numbers of people who are medically fit but remain in our hospitals. To address our delayed discharges, we have tried, within existing resources, to increase capacity. In 24-25, we increased capacity by 38 beds across all categories and sectors. This year, we intend to put in place a further 53 beds, giving over 90 bed increase in 2 years. Our domiciliary care rota optimisation programme has been a major success in increasing the efficiency of existing services. It has increased service hours for clients equivalent to 200 full-time, whole-time staff on the ground, through providers and service users working flexibly to maximise the capacity we get from existing rotas. This has transformed our ability to quickly source care packages for clients in the northern sector particularly. The issue of rurality in the southern sector remains a challenge for us and our providers. We are in the process of tendering our trust-wide service, but we aim to develop local strategies to try to address rural service provision irrespective of that. We will need support from our community groups and a range of flexible approaches to address the challenge. Turning to emergency general surgery. This sort of debate is ongoing across the UK and internationally. The challenge between local access and subspecialisation. I want to highlight a number of key developments. There is a drive to ensure that certain surgical procedures should be done as a day case, and this is a key target set by SPPG for the Trust. Many emergency patients can be treated as an ambulatory surgical patient, same day or next day, with no need for admission to hospital. Hundreds of patients receive a safe service this way every year now at both South West Acute and Altnagovan. The majority of patients who present at South West Acute Hospital ED with a requirement for general surgery intervention are now treated at the new ambulatory unit, over 5 patients per day, with 2.5 patients per day admitted for inpatient care and treatment at Altnagovan Hospital. At our last TINS at committee chair, there was a focus on the double ED journey. For the first 18 months, we struggled with getting patients direct to a bed, with only 26% of patients presenting to SWA ED getting direct to a bed in Altnagovan. From May 2025, 92% of general surgical patients from SWA ED now go direct to a bed. We all accept that delays in EDs are too long across Northern Ireland. I apologise to the public at every Trust Board public meeting every month on that. This is clearly linked, however, to the complexity of patients and the ability to assess and provide appropriate social care capacity. The small number of patients who transfer to Altnagovan ED from SWA are not the cause of Altnagovan's problems. Turning to our revised pathways, it is my role and Dr. Lavery's role to assure my board, the Minister and the public on the safety of our services. I can confirm that the Western Trust is now fully compliant with Minister Swan's revised standards for emergency general surgery. We have transformed our consultant workforce with a full substantive consultant tier and a 24/7 upper GI bleeding pathway in place. All trusts in Northern Ireland have contracts with a benchmarking organisation, as has been discussed today, CHKS, and we submit raw data, which is automatically exported from the patient systems to them, which they analyse to produce mortality, flow, efficiency, and safety and quality matrix. We now have a number of years of analysis of our revised pathways, and this data shows that as trust-wide, our general surgery mortality level has reduced by approximately 14%. That means that all general surgical patients, no matter what postcode in the West, have a better chance of survival as their clinical pathway is in line with the required standards of Northern Ireland. There's also been a 21% reduction in complication rates and a 22% reduction in readmission rates for our general surgery patients, which are important markers of safe and effective care and good clinical outcomes for patients. These improvements in outcomes are as a direct result of consolidating our medical workforce, increasing our ability to subspecialise, and have the clinical interdependencies referred to in the revised standards available to our surgical team. SOAS, as you're aware, have produced the roadmap with a range of recommendations. We were disappointed not to have had the opportunity to begin a conversation with SOAS on their roadmap last week. The Trust was keen to do so. There are recommendations we would support. There are recommendations that are for other partners and other organisations to take forward. And there are recommendations that we cannot support, either because SOAS do not have the full facts that we have, or because there are patient safety concerns with what they are suggesting. Having had a successful consultation on the temporary change, we recognise that the subsequent consultation process we proposed into the future of these services was not good enough. We did not engage well enough with partners, stakeholders and the public, leading to fear and misunderstanding about the future, both of the general surgery provision, but also for the future of SWA as a whole. We are committed to making sure that we put that right. We want to have an open and honest conversation with the public about the services we provide at South West Acute Hospital and beyond, what we can deliver, what we should deliver, and how we ensure that the services that we do provide are clinically safe and sustainable and meet the needs of local people. I want to remind everyone, however, that figures show that patients who require emergency general surgery being transferred to Altnagovan have not been adversely affected. In fact, we have seen a fall in deaths and complications in emergency general surgery since this change has taken place. So on to our next steps. A new approach to a conversation with the public, stakeholders and partners is required. With the public, partners and stakeholders, we will look again at the population health and care needs of Fermanagh and West Tyrone area to inform future work and priorities, building together a plan for our local health system, which includes South West Acute Hospital, but goes beyond to offer improved access to community services and primary care. We will start afresh with a public conversation about our local health services, what we need, what we value, and what we provide in a way that is practical and sustainable, both clinically and financially. We will build trust. We will reset relationships. We will create and follow a transparent, open, and clear narrative to support a new inclusive way forward and build a culture of cohesion and collaboration. We will provide clear, transparent information rooted in clinical evidence. We will create mechanisms of service design that create services the public not only trust and support, but which they feel ownership towards. And we will engage with our staff so that they not only understand and feel part of any changes, but they also feel equipped to speak confidently about what they mean for them and the people they care for. We will create a co-design plan for the future, which has community buy-in, is centred around the voice of the patient, and is practical and sustainable. Turning now to winter pressures. In line with all NHS and care services, winter pressures have a huge impact on service provision, and it is vital that we minimise the effect this has on the experience of our patients. To this end, we will continue to strengthen our local partnerships. We will make sure we are making best use of existing pathways and initiatives. We have given some detail in our pack, as you have got, on our preparations for winter. The West, generally, uniquely in Northern Ireland, have to address its own demand, rather than rely on system support from other hospitals, given our geography. So some headlines would be in what we're going to do. We have updated our escalation plans, our site coordination, and our site coordination hub. We have created 8 additional short-stay inpatient beds in IACU in Altnagavin. We have enhanced our staffing cover for ambulance offload and have a dedicated area set aside for that. We have mobilised same-day emergency care in South West Acute Hospital. We have added an additional 12 community beds initially in Altnagavin, and then we will transfer these to Waterside Hospital. And we've put in a wide range of flow improvements, such as community navigators and discharge coordination. Turning to elective care, we welcome the investment in elective care, but recognise there's still further funding required to properly meet the needs of our local population in a truly sustainable way. The funding will allow us to invest in elective care with 7,000 additional CT scans, 2,100 additional MRI scans, 1,050 additional ultrasound scans per year, 1,470 additional scopes per year, 495 additional general surgical sessions per year, 84 additional gynecology inpatient sessions, 42 additional day case sessions, and 84 additional outpatient sessions in South West Acute per annum. Increased capacity in phlebotomy in terms of 225 appointments per week. 8 additional trauma beds on a recurrent basis has been invested in to address increased demand and reduce the impact on elective orthopaedics. And further investment is planned across increased capacity in breast surgery services, ENT, urology, ophthalmology and dermatology. There are fundamental demand and capacity gaps across many specialties. Minister has converted the non-recurrent flow of funding to waiting list initiatives to create additional recurrent capacity within elective care, and the Western Trust patients will benefit from this with improved access as a result. It will take sustained investment alongside improvement in efficiency over a number of years to address the current lengthy waiting list, but we're already making good progress. As Chief Executive of a Trust, it is my responsibility to set out for the committee how difficult the world of a provider trust can be, and I hope the examples I have given today give you an insight into the scale and complexity of our services and the challenges my teams face every day. It is also my responsibility, and this is the enjoyable part, to let you know that every day we have teams and leaders who want to provide excellent care and change services for the better. Some examples are, I have already referenced the domiciliary care rota optimisation programme, which has transformed this vital service to all our community. In primary care, the Trust has taken over the running of 5 GP practices to sustain access for our population and prevent those practices collapsing. I want to especially highlight the 3 practices in the southern sector in Dromore and Trillick, Brookborough and Temple, and Fintona, where we have stabilised the services and then expanded the service offering and organised links with acute care. We have now managed to recruit salaried GPs, and we await the rollout of MDTs in the southern sector. As a Trust, we have transformed our adult nursing workforce, which has been referenced today. This is part of the Regional Agency Reduction Programme, and HSC are now able to demonstrate we are the employer of choice. Western Trust now has minimal vacancies in adult nursing, with no reliance on off-contract nurse agency. We are now working towards reduction in contract agency reliance, and this will further enhance and stabilise our teams. In childcare, we have reduced the number of children on the Child Protection Register by almost 30% through engagement and support of our families. Our social work vacancy rate have reduced from 21% to 9% in the last 18 months. Also, I can confirm that in recent weeks, Derry City and Siobhán District Council, in partnership with the Trust and other partners, have achieved the award of UNICEF Child Friendly Community. This is the first in the island of Ireland and the second in the UK. I'm almost finished, Chair. We have turned around endoscopic performance from having one of the longest waiting lists and to now having the smallest number of patients waiting. This diagnostic test is a critical one for early cancer diagnosis. Our track record in infection control is strong. Both C. difficile and MRSA rates have experienced significant reduction in recent years. Our imaging services are highly efficient and continue to deliver way beyond the funded baselines for specialist reporting. Our CT service is delivering at 127% of expected levels, and our cardiac MRI, which you visited today, is operating at 121% of funded levels. General MRI is also above expected levels. In relation to staff absence, we achieved a Department of Health target reduction last year and have continued to reduce absence levels in the current year. One key opportunity for the West is cross-border partnership. The Cooperating and Working Together partnerships has secured significant grant funding from the EU Special Programmes Unit to address border regions. I can assure the committee that the Western Trust is at the forefront of cross-border cooperation, with significant services jointly commissioned in our trust. We remain totally committed to this, and indeed my trust board has doubled down on that recently, and we are hopeful of further developments in the coming months. I can confirm that the COT partners have agreed 2 recent developments. First, a scoping exercise to identify further opportunities for cooperation, particularly focusing on acute hospitals in border areas. This will be coordinated by COT. Second, COT is supporting engagement between the 2 ambulance services to identify any perceived or real barriers post-EU exit to cross-border ambulance conveyance to support communities. We know at senior level in the Trust that the Northern Ireland Ambulance Service is fully committed to this, and it will become a government-to-government issue. It may be particularly important for the issues raised earlier today at committee, for mitigating concerns about travel times to Altnagavan and access to emergency general surgery for some small communities closer to Sligo or Cavan hospitals than Altnagavan. Locally also, in the Western Trust, we are working with Ciara Group to develop a formal partnership agreement to underpin the cooperation over the next decade. So locally and regionally, we are pushing cross-boundary approaches. Committee, again, through you, Chair, I thank you for coming to the West, and we are happy to take questions, obviously.
Okay. Thank you. You definitely stretched the term I said brief.
Apologies.
No, I mean that actually was very thorough, and I absolutely appreciate all the information you've given us. And I think it's important that we put on record our thanks to the staff of the Western Health and Social Care Trust and the work that they do. It's probably unfortunate that of all the stuff that you have talked about there, we literally just don't have time to just. I mean, I have 15 things that I'd like to talk about, and it wouldn't be fair if I talked about them.
You and I.
So you'll accept that a lot of what we're going to talk about is in relation to the South West Acute Hospital and this issue. So I'm going to hopefully abide by my own rules of asking sharp questions. I do want sort of decent, sharpish responses. So the figures. I think it might have been yourself, Dr. Lavery, at the last committee meeting talked about the 1 in 20, the 1 person alive in 20. So, I mean, that gave us all a really good buoyance about that decision. And so none of us are, I mean, well, certainly I can speak for myself, I'm not a medical expert. I expect the, figures that were given to be legitimate, fair, assessed and all that. So you'll have heard earlier on today that there's some dispute from the SOAS group in relation to your figures. Now, we did actually as a committee write to the Minister, so we received his response in relation to those figures literally just as the committee was about to start. So I don't really want to comment on them because I haven't read them in detail, but I would like your assessment.
If you're happy now, I'd like to give you a full explanation,
okay.
So I'll try and keep it brief. Now, CHKS, it's a multinational company. It provides healthcare data for 70% of the acute trusts in the UK. So what happens is when a patient is admitted, certain data is entered in every hospital ward in basically all of the hospitals in Northern Ireland. That's onto a legacy system called PAS. The data from PAS, once that's in, can't be altered, can't be changed. There's no human intervention after that. What happens is there's an automatic software data extract that goes to the company. They analyse it and they send you the returns. So I think it's reasonable to state that the data returns that we get are independent.
And I don't think SOAS were saying the data, there was anything wrong. But they were saying, and they were saying, even the company that carries out the testing, that the set of statistics wasn't large enough to make the data worthwhile or useful.
Let's actually look at the numbers. I think that'd be really important. Now, there are 4 main criteria that we get out. So there's RAMI, which is mortality rate. There's complications rates. There are readmissions in 30 days, and there's average length of stay. I'm going to start with RAMI. Effectively, RAMI is a ratio. Now, if you imagine you have a population in one area that's considerably older, let's say with more smokers, their death rates in surgery are going to be higher. So you have to have a way of using all of the available data to try and get numbers that allow you to compare your service with others. So one of the reasons that CHKS came in was actually due to the Stafford issue. So all hospital trusts need to have quality data to show how they're comparing and how they're doing in comparison to other trusts. Now, I'm actually going to read out the raw numbers because basically, when I talk about raw numbers, these are simple averages of the data returns. So the combined RAMI figures from January 2020 to November 22, when we had the temporary cessation of EGS and SWA, were 98.75. So you expect a number of 100. So we're doing okay in the Western Trust, slightly below what you would expect. Since the service has been moved to Altnagelvin, our RAMI figures are now 84.98.
But what about, I understand that, and I have read that, but with SOAS, I'm just trying to get to the truth so that I can be confident that, we have a service now that's producing better outcomes based on data. So SOAS are saying the level of mortality is so low that those percentages aren't accurate, and they're saying that.
So the numbers are the numbers. Now, I think, to be fair, what they're talking about is a statistical difference.
Okay.
Now, I have had this analysed using a program called HPSS, and the likelihood of the mortality fall due to chance is 5.8%. Now, technically speaking, they are correct. The value that you talk about to make sure that something is statistically different is 5%. As we get more figures, I expect that to improve.
Okay,
so I think what they're talking about is very different. They're talking about statistical difference, and I do take their point. That's why we're very, very clear with their data and with their numbers. Now, the thing is, it's not just RAMI. They didn't really touch on any of the other returns that we get. If you look at the complication rates, our complication rates, again, when we look at the pre and post change, have fallen by 20.7%. Our readmission rates are down by 21.9%. The only index that's actually increased is the average length of stay. That has increased by 0.4 of a day, which is exactly what you'd expect because we're now just admitting the sicker patients. And because of the ambulatory care that we have in both sites, they're staying for slightly longer. Okay. And I think what I would welcome, and this is a follow-up of what they've said, the data has already been shared with the regional surgical network, including all of the raw data. I would welcome a comment from the head or chair of the regional surgical network, and they can give an independent view on what they feel. Now, while you can talk about statistical differences, etc., if we were to wait, let's say, they talk to think about 1,000 deaths, we wouldn't have a statistical difference for, 20, 30 years? We can't wait that long. We need to have assurance that what we're doing is safe and it's right for the population. And all of the evidence I have so far from CHKS is that our outcomes are better. Okay. Now, the other thing is, none of this is unexpected. This replicates the national, the international evidence that we have. We have our EGS safety standards, which were published in 2022. We now fully comply with these. We've got the only upper GI bleeding rota 24/7 for all patients in the Western Trust outside of Belfast.
Okay.
You know, all of this is what we would expect to see.
Okay, fair enough. So I'm going to move on. I'm just going to try and get as much of this, my questions on as I can. So the 92 empty beds, I mean, we heard that a couple of times. So if we could get some explanation, is there 92 empty beds and why?
I can comment on that, Chair. All adult beds in this hospital are full. And today, and I checked just before coming to the committee, we have also 22 escalation beds in the hospital, as well as all of our normal adult beds. We don't fully understand the basis of the 92, and I mean, I would be very, very happy to meet with Ciara.
They seem to say it was Neil that said there was 92. I think they quoted that during their presentation.
No, that's right.
So you're saying this isn't something you're aware of?
Information, Chair. No,
okay.
No. So the beds in the hospital. Obviously, there was a business case originally, and I think that's possibly what the Save Our Acute Services have looked at. Business cases change over time and up to the opening of our hospital. So when the hospital opened, we have very set numbers for the numbers of both inpatient beds and of day case beds or ambulatory beds in the hospital. And we're very content to share those, Chair. In fact, I think we issued a press release probably over a year ago setting all of that out. We do have wards in the hospital which are not commissioned, as you know. We have Ward 4, which I'm not sure if you saw today, but Ward 4 is currently in use by an independent sector provider who use one of our theatres, and that is through an in-year waiting list initiative arrangement. We have a second ward which was never commissioned, and that is Ward 10 in the hospital, and Ward 10 was actually converted before the hospital opened, so it is non-clinical and some clinical space in it. It is not a ward anymore. Now, obviously there are other beds such as paediatrics and critical care, which may be empty at any one time, but you cannot fill them with general adult patients. So other than that, Chair, we do not have the information that is able to take us to the 92, which SOAS have put in their information.
I'm sure they'll probably come back to us in terms of that.
That's fine, and I would be happy to engage on it.
Okay, that's just. I'm just going to shift right, as it were.
That's a political statement,
It's not something I'm known for. But in terms of the vision, so I mean the consultation was collapsed, and the minister made a request for a speedy vision. And I mean, we've heard the alternatives, and you've given clarification in terms of what you actually said. But I mean, where are we with the vision? How long will that take, so that we can see something in detail, and what kind of engagement will take place? Before we get that, because I do think, I mean, one of the disappointment things for any politician is, you know, this kind of at odds between communities and public servants, as it were, and I think that's disappointing. And there's no doubt I've had engagement over the last couple of days, but well beyond that, I mean, I'm aware of that lack of trust within some the decisions and maybe even the leadership and all the rest of that, and I think that's disappointing. So I think engagement, proper engagement, and a quick delivery of this vision in some small way could help to repair that.
Well, I think that's right, Chairman, and we have invested in very urgent correspondence to try and have that meeting that you would have been aware of last Friday, and we went out of our way to try and facilitate and get that to happen. But on balance, at the end of that exchange of correspondence, the SOAS group decided they didn't want to meet us, and I have to say, having listened to them today as they spoke to you and responded to you, I didn't get a sense that they were ready to change their position on that, which I find is very disappointing. But that won't stop us from moving on to develop the vision, because I think we have to recognise SOAS is an important and a very central part of the community voice here, but there are also other voices that we need to hear from as well, not in any way that may be counter to it, but what we're trying to look at is the system in the round. It isn't just about emergency general surgery, it's about the whole profile of service moving forward that we need to be designing, and that's why we call it a vision rather than a specific plan. We've certainly, and I'll ask Teresa to maybe go into it, because she's been very central to designing that, and it is ready to roll, I think. And I'll ask her to confirm where we are with it and what the first steps will be. But I assure you, it will not be for the lack of our commitment to get it done urgently. Okay. The point I make again is, I have been in the health service, and this is a sad reflection on me, since 1971. I have never seen a financial circumstance that we are in. And no one should try to underestimate what that means to us. And I will go even further and say, as a tired old man, that I will be astonished if, without some relief from Westminster, we don't get some additional resources. Then we will be making some, not decisions about investment or development, but decisions about contraction and decisions about rationalisation, because we won't be able to afford what we have. Now, I don't want to be a doomsday, but I do think the numbers now are becoming impossible. And that's a political thing for me to say, but it really needs to be realistically seen by our public that this is a very, very difficult moment for the health service as we know it. And we are going to have to, or else we need to see some, I think, very difficult choices. So the planning of the service going forward will become crucial about what are absolutely essential investments going forward. And that's why the vision becomes important. But I'll ask Teresa to speak to that.
Thank you, Chair. So, Chair, we recognise and accept that the second consultation, which we did on the permanent withdrawal of emergency general surgery, was not good enough. We did not engage early and well with our public and stakeholders, and the process was too rushed. And while public meetings are only a part of a public consultation, because we wrote to many people, interested groups, and would have gone through a process of inviting and speaking to those groups during the period, the public meetings did gain a lot of attention, and the dates of those, the judgment around the dates of those was wrong. And we accept that, and Neil, on behalf of the executive team, has apologised for that. The Minister, of course, has asked that we do visioning work. He did, in his correspondence to us, of course, refer to SWA and a vision for SWA, but he also referred to our population and the needs of our population. So as we have reflected on the work and as the executive team have considered what next steps should be, we felt that that issue of population need, the broad need, and what our population in Fermanagh and West Tyrone value and want needed to be where the conversation took place. That does not exclude SWA, it includes SWA, but it is not only SWA. We have a hospital before the change to emergency general surgery, which in the main treated and supported medical patients, not surgical patients. And in fact, given the demography that we have in this geography, with a growing older population and what we call many multimorbidity, which is people who have 2, 3 and 4 disease types, chronic illnesses, we need and must have a health and social care system that supports them well, primarily in the home, and also supports them through primary care, where we can give assistance to that. So we feel there is a bigger picture on this, Chair, and when we have our conversations with the public and all of the people who are so interested in health and care in this geography, we want the conversation not to be constrained. We'd like it to be about the broader picture. Okay. So thank you, Chair.
Thank you. Last question from me, and it's just following on from the point you made, Tom, about the situation we're in with regard to health. I mean, I have my own political view about what we need to do to improve health services on this island, but it actually is a view that's shared by so many people here, and I don't mean in terms of an all-Ireland health service, but certainly people in this area can't understand why this hospital isn't used as a centre of excellence in terms of cross-border acute care, and you know the accusation, as it were, about COT was that COT works well in the Western Trust for the northern part of it, but that there isn't the same emphasis put on it. I mean, it makes absolute sense that Enniskillen is tied into Cavan, Monaghan in terms of any healthcare. So, I mean, with regard to pushing forward cross-border initiatives as part of this vision plan, where are we, or how important is that?
Well, firstly, I've outlined the work that we're doing through COT and both also locally within our trust and the Sailshire group who covered Galway to Donegal. We have to outline the difference between the commissioning of Northwest Cancer Centre, which was organised by government to government, is linked to the access issues for the patients in Donegal who would have to go to either Galway or Dublin. There are two types of arrangements. There are emergency and elective. We've had real difficulties actually getting commissioned any sign of elective work from the south, because every piece of elective work we do is a work that they won't be doing themselves. So they are commissioning, you will know that they have commissioned hundreds of millions of euro worth of elective hubs in Sligo and indeed Letterkenny and elsewhere in the south. That is their strategy. However, we're trying to get into that. We're trying to use the COT, and the Southern partners have agreed to the feasibility study to identify those areas that both governments really want to actually cooperate on, Chair. So it's about, you need two partners in a partnership, and it's really, we need to bring the Southern government with us. And there's no point in us telling them what to buy off us. It's really around getting people around the table to say, well, what are the gaps in either your access or in your needs? So and that's the process we're going to have to go through. But be clear, to date, it's been primarily around emergency and things, specialist care like cancer.
The other dynamic, I think, Chair, just is really powerful. The people in Cavan want Cavan Hospital to succeed. The idea that you're going past Cavan to go to it. I mean, communities gather around their hospital in a way that's incredibly protective. And I mean, I respect them for that, vitally important. But local politicians then in that situation will articulate the interest of their own local hospital. And we have a cluster, as Neil has said. You have Sligo, which has had huge investment in it. They now want to see that investment realised. You have Letterkenny, who see Altnagelvin as a competitor nearly, and there's tensions in that relationship. So unless we get that political engagement, then that creates the atmosphere and the environment in which we can promote these sorts of solutions. And, we don't want there to be winners and losers. But the reality is that people will try and protect what they have. And that's the tension that's in the system.
Can I just finish as well, go back on the COT point? I can assure you, the COT partnership is for border counties. It's not about one border county. So I would welcome the opportunity to actually ask COT to actually present to the committee, to give you information about the beneficiaries of the various projects that they've fantastic projects ongoing now and those that have been completed. And they have very clear analysis, oversight from the EU. And I can assure you that is not the case, that Fermanagh has been left behind in that. As a former Director General of COT for 2 years, I can assure you that hasn't happened.
That's actually a useful suggestion. I'm going to move on. I hope that the members will pick up on the 17 or 18 issues I've left behind here. Colin.
Thank you very much, Chair, and thank you for the presentation. And look, I think it is fair to say that we got the tour today, and what we saw was excellent. We saw staff working very hard, people getting the health outcomes that they want, and that 95%. I think we need to bank 95% going wonderful and going great. Mm-hmm. I've been part of talks processes to get the institutions up and running again, and I've seen 95% of the document doing grand, and the last 5% nearly bring blows in the room. So we'll not get that far, but I just appreciate that it's always maybe those last little percentages that can cause the friction. So it's not that we're just gunning at you for this particular issue of emergency surgery here and not recognising, first of all, that it's in a landscape where there's fantastic work being done right across the board. But it is just as well, and I welcome the fact that you've sort of said on numerous occasions across the presentations that maybe how we interacted with community groups and organisations could have been done better, and could have maybe at a much earlier state got us to a point where we wouldn't be in maybe the standoff that there is. And some of that information that we get fed doesn't make sense in our head, and then that's why we ask it here. So in that vein, one of the questions that I wanted to ask was about the number of consultants that you have, because obviously to be sort of probably quite black and white, straightforward about it. There were X amount of consultants here, X amount of consultants in the Altnagelvin, and then the service wasn't sustainable here because of those numbers, so everything has been centralised now up into the Altnagelvin. So what were the numbers before and what are the numbers currently?
Yeah, so we struggled to recruit in the Southwest Acute site for quite a long time. From memory, we had a total of 4 permanent consultants out of 6. We were reliant on a locum workforce. One of the things that's kind of lost in the narrative is when we had to remove the EGS from Southwest Acute, it wasn't a decision. We had 0 consultants left who could work out of hours. That was due to basically resignations and also due to the safety standards. Now, I wasn't involved in the safety standards, but a lot of the consultants across Northern Ireland, including those who worked in Southwest Acute, drew those up. So a lot of the individuals that worked in this hospital drew up the emergency general surgery safety standards, knowing that they would struggle to comply with them. Why? Because it's best for patients. Now, moving on to the question you've asked about the consultant general surgeons in Altnagelvin, to the best of my knowledge, and I may be off by 1 or 2, I think it's 14 consultants in general surgery. So I think the number that was quoted of 20 is incorrect. It probably includes perhaps trauma and orthopedics or ENT who don't, or breast, who don't contribute to emergency general surgery.
I appreciate it's more difficult for me to understand, easier for you, but I'm still none the wiser after that there. So how many, so you're saying there was none out of 6 here whenever you had to close the service down, and then how many at that stage were there in Altnagelvin?
I would have to get back to you. I'm not that closely involved now. We had, I suppose to generalise, we had 2 struggling rotas. So we didn't have a large number in Altnagelvin. And when we've consolidated, what we've now managed to do is, while fully complying with the safety standards, we're now moving to a stage where we're going to have an upper GI and a lower GI rota. And that means that patients get better treatment because there's always somebody who specialises in the area that they want when they come to hospital. One of the things I'd really like to get back, and if you talk about the data, this isn't just about Southwest Acute. The data that I quote, the combined figures, they're combined figures for all patients in the Western Trust. We can't forget about the patients who have and always have attended in Altnagelvin. Their outcomes are better as well. This is an overall win-win for all of our patients.
I get that, but I also get that that's a development of a service that you're developing after you've made a change based on numbers. But what I'll park it with this, just saying, could you maybe come back to us and tell us what the figures were before and what they are after, and then we'll make our own determination whenever we compare like for like. And I'm not saying that if you put them all into the one site and then that becomes more attractive and then you develop more services, but then that becomes a decision. And I think it's fair to say, and I really do accept the point that you make, Tom, about that the situation in terms of finance of our services at the minute is really close to the brink. It's the worst that it's ever been. But again, on that means that maybe some of the changes that have been made have been taken for financial reasons. And people are saying, no, it's because of clinical safety. But I know that we're increasingly moving into the territory where we will have to take them on the basis of financial decisions rather than clinical outcomes because the finance is so bad. But in terms of the RAMI figure, and we've had the discussion about whether we think there's a representative sample big enough in order to derive the right amount of figures, i.e. if 2 people come into this building today and 1 dies, 50% of your patients that have come in today die, but if 10 patients come in and 1 dies, then only 10% of your patients die. So it depends on the size of the representative figure as to what those extract. But there was reference made, and I have heard this before, the weighting feels like it's disproportionately put on those figures. But was consideration given to the fact that the longer that people have to wait can also have a detrimental impact on people's outcomes, and therefore if you're putting 2 services together and then people have to wait longer, or the references to double waiting, has there been any assessment done of the outcome that's having negatively on people?
So I have, and this is a separate sub-analysis. I've looked at the mortality rate for emergency general surgeon patients by GP practice postcode, and that also shows a decrease in mortality. I've also looked at the standardised mortality ratio in general surgery, and again, that also shows a decrease in mortality.
But also, that's not the only indicator of a health outcome in terms of our people's health outcome. Maybe if they were coming to here for a service and waited 5 hours, they would get an outcome. If they have to go to Galvin in the one base service, if they have to wait 15 hours, then it could be a different outcome. Has there been an analysis done on how long people are waiting now after the amalgamated service versus what it was previously?
Well, as I say, the primary stuff that we get from CHKS, we've gone through that. That's really it's kind of an oversight view as such. There's also a group that we call the Rapid Review Group, and that looks at any adverse incidents. So anyone can submit an adverse incident, doesn't matter what grade or level of staff they are, if something goes wrong. And sometimes things go wrong, not due to anyone's fault, but there is an adverse outcome. What we then do is we do a serious adverse incident report, and we look into what happened. And in all, since the temporary change has come in place, there has not been an SEI which is showing that a patient has suffered a detriment that wouldn't have occurred if the service was still present in South West Acute. I hope that kind of answers your question.
It's getting there, but there are facts and figures that we can check for that to get an outcome from it. But look, the final question then, the initial change that was made here was temporary. Can you give us a flavour of the work that you had done to try and prepare for a service to come back in again? Did the recruitment exercises, did you have meetings, did you have a strategy, have a separate strategy group that maybe met to be able to try and implement? Because if it was temporary, obviously you've got two potential outcomes. You have the service that you currently have, but if it was temporary, you may have come to the stage of reintroducing the service. So what sort of work was done to try and reintroduce the service again?
Well, I'll start. Maybe do you want to add that?
Colin, it would be a new service to be reintroduced. So the emergency general surgery service that we had prior to the temporary cessation back in December 2022 was purely about workforce, and Brendan has described we actually had no staff to staff the out-of-hours rota. We had no consultant staff. And the emergency general surgery standards were introduced in June 22, and in the material we've provided you, it shows you that when they were announced there was an expectation that all trusts and all hospitals would move to implement those standards. So in order to implement those standards in South West Acute Hospital, we essentially would need to bring in a range of new and additional or enhanced services into this hospital in order to, as well as consultant general surgeons.
To maybe on that, did you have a strategy group to try and achieve that? Was there recruitment exercises done nationally, internationally to try and recruit people in to fill those posts to deliver that service? Or
how would you recruit to a service that doesn't meet the standards?
Well, if it was temporary, then if you only provide the alternative, then it's not temporary. You're just temporary whilst going on a journey.
Temporary or permanent, you can't recruit to a service that doesn't meet standards. How would you attract a doctor, to even ask a doctor to come from across the world to a service that doesn't meet the standards? That's a fundamental point, Colin. We would need the building blocks in place to actually, before you even start to consider the recruitment of doctors to replace, to basically commission a new service. It's a completely new service, post standards.
It's not really a temporary cessation of a service, it's an immediate removal, because there is no, that's not necessarily your fault.
I totally agree with you.
No ability to replace that temporary
Yes.
facility because there's no capacity to do it. So
maybe just
until somebody decides to actually commission that completely different service.
So, and I was going to say, so one of the things that we would be required would be to get a renal team here. There's no renal medicine team that is being commissioned. We can't bring in a service that we're not told to and we're not given the funding for. Another one would be intervention radiology. And again, all of these things are needed for us to provide a safe surgical service. We can't do this on our own. If the Department of Health said we will commission those services, that would be a very different conversation.
I know we're under pressure, so I'll leave it there, but I have a recommendation to make at the end.
I was actually going to allow you a question, so I'm going to make the question, we could talk here for days and weeks about a temporary removal of emergency surgery. So I'm just going to ask a very straight question. Is emergency general surgery ever coming back to the SWAT?
I think at the end of the day,
it would be a new service.
It would be a new service if it was to come back.
Okay, so, and that is above the trust decision. So if emergency surgery is coming back to the Southwest Acute Hospital, as Solus and a large group of people here want, it has to be the Minister of Health that makes that decision in the department.
Well, it'll be the Commissioner.
Okay.
Yeah.
Because it's a fundamentally different service.
Okay.
And it's very different to the framework of this hospital. It's a different service. But remember, we will go back to our numbers at the start. We have 2.5 patients a day being admitted for emergency general surgery in Atmagavin from this area. If you were to actually commission the new service, you'd be bringing in significant numbers of consultants outside of general surgery to get the clinical interdependencies for 2.5 patients a day. That's the dilemma that the entire service has, and I don't want to dress that up any other way.
Yeah.
That's the dilemma that health and social care has in Northern Ireland. For 2.5, you would have, because you need to get a bleeding rota. I don't know how many.
You need 6 gastroenterologists
So you need
available
6,
24/7.
24/7. You would need an interventional radiology. You would need an entire renal service for 2.5 patients a day to support that. Okay. And my understanding is that.
Could I just say, Chairman, in some ways you've hit the nail on the head in terms of the problem we had with the consultation process.
Yeah.
Because I think if you take the logic of your well-made points, there is inevitability that this won't be back, because once you've stopped it, you cannot meet the new standards. And you are asking, and we are required to, by virtue of departmental policy, to go and consult on that. Now, how do you go into, and I'm saying this as a chairman of a board, how do you go into a public meeting to say, we want to consult on, but by the way, we can't bring it back anyway, so whatever you tell us, whatever your perspective on it is, we can't, as the individual board, make that judgment. That would have to be a realignment of services across this region in order to facilitate that way beyond our control and with additional expenses that we haven't even contemplated. So that is the real dilemma, that our people are feeling really frustrated that here we had to consult on a temporary closure because that's what we needed to do to deal with the complete departure of consultants. And we did that and we got it through. And then people could argue, yeah, they represented as a temporary closure, but then they knew that they didn't have to go the whole way back. Now, we then knew that we would have at some point to have to go out and consult again. And therefore, we knew this is exactly the conclusion we would reach. So, I mean, we feel we're being used by a system, and that's how I feel.
Okay.
These people go out to consult, and we then are treated with complete skepticism by a public who say they really aren't sincere about this at all. And you got the demeanour and the feeling, an understandable feeling that the public in Fermanagh have to us. But that's the circumstance that we are in. We can't do anything about that. Those are the requirements placed on us. And so we're trying to figure a way out through it now that will allow us to try and rebuild that trust, because that's hugely important to us.
Chair, just my final
go ahead.
comment for 10 seconds just is that maybe what we need to investigate, when we challenged this originally, the department, whenever we go to the department, says, oh, it's a temporary decision. That's a decision that the trust makes, so the department couldn't speak to us about it. Yeah. And then whenever the department then tells us that there must be a consultation, the consultation can't change it because it takes the department to do it. And I think it might be worthwhile for us to contact the department to ask them about that procedure of how something is deemed temporary.
Absolutely.
And then what the outcome of it is, because I do feel it creates sides where there maybe aren't sides, or where
there's a lot of smoke and mirrors.
Yeah, then it would be good to iron that out from the department perspective.
No, I think that's been useful.
Chair, could I just say that while the temporary word is used, that is a word that is used in the department's own circular around change and withdrawal of services. This was an emergency.
Yeah.
By dint of that, it was temporary because it had to happen very quickly. Because it had to happen very quickly, we could not have consulted in the normal way that any organisation would properly consult before that change happened. So I think of it as an emergency change, but the circular calls it a temporary change, and that's the language that we use, and that's why we use it.
Okay.
Probably unfortunate, in fairness.
Yes.
Okay, we've been talking for 2 hours, and I think
that's indeed, Chairman.
Yeah. Okay, Danny.
Thank you, Chair. And I would echo the Chair's earlier comments just about thanking you for your hospitality today and the tour and meeting your staff. You know, it was very, very informative and very useful to see everything actually in action. Before that, this morning, we met with representatives from local businesses and the local councils, so stakeholders in the community, and they expressed to us their concerns. And there certainly is concerns, and maybe things haven't been communicated very well, particularly around the new standards. And particularly around the possibility of the service coming back. What we were getting was, well, what certainly when I heard, was that there was a suspicion that when the service collapsed effectively because you had no surgeons, that then there was a reluctance to recruit other surgeons just to restart it effectively. Maybe you could talk to that, but obviously we've just heard today, obviously, that there's a lot of other things that need to happen now because of the standards, which make it very, very hard, if not impossible, for the service to come back. But just on the grounds of being able to recruit patients or being able to recruit surgeons to the area, what were you doing to try and bring surgeons into the area?
Well, we were trying to recruit, I can assure you that. The challenge is, it's a really, really difficult sell when you have small rotas against bigger rotas across the UK. Also, the whole of the UK is moving towards consolidating emergency general surgery. And it was at that time, it was in the aftermath of the standards. The standards came in June 22. And in fairness, we knew that the standards were coming in advance of that. And we knew that the review team had concerns about the smaller hospitals in Northern Ireland. So we weren't operating in a vacuum, Danny. We were operating in a situation where the labour market knew exactly what was happening. So to say that we weren't recruiting whatever is cart before horse. You know, at the end of the day, if you know you're not going to get any candidates coming forward, and it would have collapsed because eventually people were, when we talked to the people who left at that time, because they come back and do elective work here, they are very clear that they had to leave because they wanted to continue to work in emergency general surgery, and they knew that that would not be the case when the standards came out. So which comes first, Danny? Is it the standards or is it the collapse of the rota? They're both intertwined. You can't separate the two out. And when you talk about meeting with business leaders, I think was it you were talking about? I can assure, yeah, well, I can assure you we will be meeting with the business leaders. We have a meeting on the 15th of December, and we will talk through because they have a range of concerns, and I'm very confident that we will be able to address those concerns in a positive way with them. The vast majority of those concerns, where they're reasonably placed, we will definitely be able to show the outcomes that we have. We will be able to show that this is a thriving hospital. And that actually, from an employment basis, which was one of the points they raised with me, well, this is expanding, this hospital, not contracting.
Yeah. No, I'm glad to hear that. I'm sure those businesses would be welcoming to having that meeting and
yes,
to have that reassurance as well. One of the things we've seen across all trusts is medically fit patients who can't be discharged, and certainly at this time of year it becomes quite a significant problem. I'd recently asked the Health Minister about this, and one of the answers he gave back to me was a specific day, halfway through October, there were 400 medically fit patients across trusts in Northern Ireland awaiting nursing home placements or care packages within the community. We've heard today that that's a significant problem here because of the geography in the area, that it's quite hard to get care packages in rural areas. The cost of that to yourselves as a trust, how much is that costing you as a trust, those patients who are staying in hospital for long periods of time when they're medically fit, compared to the cost that it would cost to pay for their care in the community?
Danny, effectively there was two questions in there, and I'll try my best to answer them both, okay? You're absolutely right. The biggest issue, and one of the reasons why we've expanded our vision work to include the community services and primary care, is because the biggest challenge, and when we met to engage with the staff, yes, we had a very difficult conversation at the start about emergency general surgery, but one of the sisters in this hospital said, of course, the biggest issue facing this hospital and most hospitals in Northern Ireland is the patients that we can't get discharged. It's not about two patients here every day. So to me, that is the biggest issue facing this hospital. It is an equal problem in Altmagavin, albeit with different nuances. When you talk about the cost, it's really interesting. I think it was the last time I was at the committee, the comment was made, you have patients in the most expensive bed and you're not releasing them into more cheaper beds in the community. I'm going to try some really clumsy maths in this. And Chair, please don't assign a maths lecture or anything on this, but I'm going to try to work my way through this with you. In terms of a general acute bed in a hospital, it has a length of stay of 10 days. So, roughly, it can be 11 days or it can be 9 days. But if you use 10, because my maths can just about cope with that, that means there will be 36 patients in a year through that bed. Let's look at 3 years. That would take you to just over 100 patients going through that bed. When you go to a dementia care home place, the average length of stay is 3 years. So over those 3 years, there's 100 patients going through the acute bed and 1 patient going through the dementia place, because it's their home. If we replace like for like, what do you do 11 days later when the next patient wants to be discharged? Because you've done like for like. The reality is not every patient going through an acute bed requires dementia placement. However, as the population gets older, and we've done all the ambulatory work we can do, all the reablement we can do in the community, you really are only seeing the later stages of people's needs being focused on in hospitals. There's a higher and higher percentage of people needing those places. And I would also highlight the fewer places we have in the West compared to the rest of Northern Ireland. I am astounded coming into this trust 6 years ago with that level. The 500 nursing home places, less than any other trust in Northern Ireland. We get our capitation funding, so we can't say that this is all totally unfair. It goes back, I believe, to the whole deprivation and deprivation funding and the need to actually have a special case. So I hope I've answered your question there in terms of we can't. I think we're a £1.1 billion organisation. We're being strangled in relation to the last 10 million being spent in social care. But let's face it, that's what's stopping patients getting out of our ED into wards and getting out of our wards into nursing homes and into domiciliary care. We've done a cracking piece of work in domiciliary care in the northern sector and southern sector. It's just that the rurality in communities, we've seen villages in Fermanagh and West Tyrone have really struggled to retain the younger population who would be able to be the carers for the older population. And that's something we really have to engage with community work, community groups better on. But we've done as much as we can internally, I can assure you.
I'll give you just the figures, Danny, if you want to know, and just on the 2 hospitals, but we can send you any more information afterwards. So in Altnagelvin, we have 24 complex patients waiting care homes and 5 awaiting domiciliary care packages. Okay. And we tend to have a very good supply of independent sector provision for domiciliary care through that work that Neil referred to earlier and in your briefing around road optimisation. It's almost the flip process in South West Acute Hospital. So we have 10 patients, complex patients, these are awaiting care homes, and 25 awaiting domiciliary care, and other patients over and above that that are in the assessment process so that we can determine what their needs are and try to secure the provision of those needs. So domiciliary care is a really significant issue for us here in Fermanagh and West Tyrone, and that is about workforce supply. So young people who actually want to be carers and work in that profession. And we're working really, really hard, our director with responsibility, not just to do the tender, to try to get the interest in the market to provide. And we did have a provider here in this geography that stepped out of the market quite recently, and we had to go in with contingency arrangements. So to generate interest in the market, and if that interest can't be generated, we are going to have to do something else about how we can provide for those patients rather than those patients not having provision and having their care here, essentially in the hospital.
Can I just make one point, if I could, Neil? I think the other bit of it that I think we shouldn't understate is that when you have the limit on availability of nursing home places, particularly for dementia patients, then the cost escalates because those who have the places are looking at you as if to say they know you need to empty this bed. So, the cost that might have applied had you a surplus of beds does no longer apply. And so the market is managing us. We're not managing the market. So it's really difficult for us because you're trading off our capacity to do other things in order just to move someone, which is totally understandable from family point of view, from our staff's point of view, but then the affordability issue hits you and you say you can't keep replicating this.
I have made a recommendation, Danny, to the Department of Health. If you look at the Republic of Ireland, I think the future to this has to be down the direct payments route. We have made the direct payments process in Northern Ireland the most cumbersome that I have said to the Permanent Secretary. I'm a chartered accountant by training. I've been a director in health and social care for 27 years. If I had a debilitating injury now and needed a package of care, I would refuse direct payments because they're so complex. You have to be an employer, you have to have an organisation, you have redundancy commitments, insurance, all sorts of commitments. My argument is, why not just make them grant and aid? So that people get the money. We trust the community of Northern Ireland to actually look after themselves. Yes, have checks and balances through district nursing or whatever to make sure that Neil Guckin doesn't waste the money on something else, that he does get generally care. But to me, I think that's the future.
I would come in there. I know a lot of people who use direct payments, and they use people like the Centre for Independent Living to
absolutely
help them to manage all.
It's still very complex. It's still and yeah, totally agree with you. But a lot of people are still put off by the whole package, the whole surroundings.
But there is support out there.
Oh, there is, yeah, absolutely.
And certainly the Centre for Independent Living do great work. And
oh, absolutely support
in doing that. One thing that just came up there, you mentioned it. I think it was Teresa had mentioned it, just about the market and the market for care in the community. Now we're talking about people's needs as being a market. Now it's something that is kind of uncomfortable with myself, and I know it's just the reality of how the health system is set up is that that those needs need to be met in the community, and there isn't the capacity to do that. That reflects then back on yourselves, and particularly with the geographical element to this. People wait a lot longer in your hospital beds than elsewhere.
I suppose, Danny, the policy in Northern Ireland is to have a mixed economy, but for nursing home places in Northern Ireland, generally speaking, there's maybe a couple of exceptions. Trusts don't provide nursing home places, and that's dated back quite some time. I personally think, looking at the numbers, and I know people, not numbers, but the difference between the private sector and the statutory sector is narrowed. So I think people like myself have been considering going into that market, quite frankly, because to make sure we get the capacity. So I think that will be blurred into the future, Danny. I can see a situation where the health and social care actually commission and to provide nursing home places into the future, where particularly in areas where we can't actually identify a market.
But it suggests to me that the market isn't working at the minute. If we have patients who cannot get out of hospital,
well, I think it's a combination of multiple factors. I think it's resources are probably the biggest issue rather than the market. I think if we had the resources, we were able to go to the market with a genuine state and saying, wait a moment here, here's new money to actually expand capacity. We've been able to create. We were told 3 years ago there was no spare capacity in the West. Well, but in engagement with all the providers in the West, we were able to persuade them, well, what's stopping you opening these 2 beds here? It's workforce. Well, can we work with you in terms of access to agency staff or access to recruitment to help you maximise the capacity that you have in your home? That's where we've got those 91 beds I talked about in my introduction. So we can work with our providers now, and I have to acknowledge our providers are excellent. Let's be clear. There's no difference in quality between the independent sector and the statutory sector. They're providing excellent service for us. We are working towards developing a dementia tariff and things like that to try to make it a more nuanced relationship between ourselves and the independent sector, and that's good work being done regionally.
I have 2 quick questions, if the Chair lets me. One of the things we've heard again and again is about short-term contracts. So can you tell us a bit just about the amount of contracts, particularly nursing, we've heard of today, nurses being offered short-term contracts rather than full-time permanent contracts that allows them to be stable in employment here and being able to move here and live here?
Well, the first thing I will say is we have transformed the nursing workforce in Northern Ireland in health and social care. And I chair the Regional Agency Reduction Group, and Minister Siobhán appointed me to do that because we had a scandal, it's probably a word for it, whereby the costs of off-contract nurse agency had spiralled out of control in Northern Ireland, and that was about the market and because there was a workforce issue. By actually banning off-contract nursing, we were able to then have proper contracts with the agencies we will need, because there will always be some need of agency nursing. But what we've also did, we changed the contract awards, and over the next 4 years, we're actually bringing the situation where a nurse in an agency doesn't earn significantly more than the substantive staff. So what that has done is that has made us more popular as an employer of choice. For the first time in history, the Western Trust had 0 vacancies in adult nursing. We're not an employment exchange, Daddy. So really what we're trying to do now is if we can convert our use of contract agency, we will then be able to avail of the waiting list we have. It was 95 nurses on our waiting list for vacancies. It's down to 61 or 62 within 2 months. And over the winter, there will be natural turnover of staff, retirements, etc. So we anticipate everyone on the waiting list will get a permanent job. But because the marketplace is different, there will be people it's more difficult to get a job in nursing in trusts now. But I would also highlight we're not the only employer of nurses in Northern Ireland. The independent sector has traditionally been forgotten about in terms of their needs for nurses. There are a range of other opportunities for nurses. But I'm really, really proud of the work we've done. We've really consolidated our nursing workforce in the West and indeed across Northern Ireland. So and this is work with the unions, whereby we no longer have that situation where agency staff are earning significantly more than the substantive staff. We're the only jurisdiction in the UK or Ireland who's managed to do that. And they are coming to us to ask us how.
And certainly that is to be commended. And the situation at the minute where said we would always need agencies, certainly I would see the expansion of banks, nursing banks, to be a solution to that.
Absolutely. I suppose it all comes down to safety. And we have to avail of a bank, and we're looking to modernise the bank as part of the project. It's got 27 work streams, the agency reduction group, and one of those is the reform of the bank. But I believe you will always get that phone call. You will always get that phone call at 9 o'clock at night or 8 o'clock at night on a Friday or some day in the week where somebody isn't able to come into shift, and the only person available will be an agency. But the whole point is to minimise that and maximise our substantive staff.
My last question, if you trust Cherrie, it's just about those GP surgeries. The GP surgeries that the Trust took over. You'd mentioned just in your statement there that you had been able to recruit salaried GPs now to that. Is that in a specific, I think there was three trusts in particular you were speaking about?
Three practices.
Or three practices, right.
Well, we have 5. No, we have 5 practices, and I think all 5 actually have salaried GPs.
Okay. The cost of them, is that reduced now because you're...
See, what we had when we first took over, these were practices were really struggling. And there was one of the criticisms of our local GP federation, and they were quite right, that we were coming in, we had to sustain the service, so we were paying locums for most of the shifts. So as a result of that, we had a programme of recruitment of GPs, salary GPs into the practices, and that's been really successful. And we're going out again, just for everyone listening. There will be opportunities for further GPs to work in the Western Trust as salary GPs, and we're open for applicants as we speak.
I think, Danny, just powerfully what we've learned from it is this, that increasingly now the majority of graduates in medicine, particularly those choosing general practice, are women. And the reality of younger women now is they don't want to work full time because they have children or whatever. So the idea of running a practice does not appeal to them. They don't want the administrative challenges of HR and tax and all the other stuff, discipline that goes with it. They just want to turn up, do their clinical work and go home. And so I think this is going to be a very, very new and very important innovation for us. They also are much interested in mixed work. They're interested in, I'll do 3 days in general practice and I'd like to do 2 days in a specialty in SWA, for example. So I think it really is a very important moment for us. Now, one thing I will say, I do think the current relationship issues between the department and the general practice community is not helpful to us, and we need to find a solution to that problem. Because we need GPs. I make the point all the time in primary care, and I'm reminded constantly by my colleagues who are a secondary care trust, but I make the point that general practice is crucial for us because it's our only filter. It is that gatekeeper, and if we lose that, we will then really experience huge problems.
Thank you. Thank you.
Thanks very much, Chair. Chair, I've a couple of questions. I'll group them all together in one breath just to speed things along, but just echo the sentiments of the rest of the committee. It's been a pleasure to be in this very impressive hospital today. But regarding the temporary removal of the emergency general surgery, it's not just the impact on this hospital and on Enniskillen, but it's likely had a big impact on ambulance services locally too, and I know that there has been some third-party capacity brought in. But is it also the case that the SWA bypass protocol is unnecessarily bringing patients, perhaps older people suffering from maybe just something as basic as constipation, and who wouldn't require emergency surgery, or been taken on long ambulance journeys whenever they could clearly be much better served here in the SWA? Second question is, I've often heard it said in the Assembly that this hospital is now busier in terms of elective care, that is, more surgeries and treatments being delivered now than it has ever before. And just to confirm, is that the case? And my final point, Neil, is I've got a flavour of the challenges that you face in trying to bring back the emergency general surgery to the SWA. And you've given us a bit of a reality check about that it's not just general surgeons, it's all the other ancillary specialities that would have to be on the site 24/7, or certainly within local call to be able to proceed. But could you sort of tell me, I know Colin sort of alluded around this, but what's the absolute minimum number of general surgeons that you would need employed on this site to provide a safe 24/7 general emergency general surgery service?
Okay, I'll let Dr. Lavery answer the questions, but for the first question, it was actually covered in the RQIA review about clinical audit. We should be doing more clinical audit, and I'll let maybe Dr. Lavery talk about the results of that clinical audit that we've been doing constantly. But you need a cycle of patients to get your clinical audit done and assessed. But
okay, so I suppose first off that we do have to realise that our elderly population is a very different cohort. So if you're an elderly person with abdominal pain, statistically you're much more likely to need intervention operations. You have a higher risk of death. So it is entirely appropriate for safety reasons that we have the bypass protocol. We should not take a patient to the wrong hospital, because if we do that, that means there has to be a secondary transfer. Effectively, you're talking about 2 ambulance journeys. Right? So it's really about safety, it's about using the resources as well as we can. What we do have in place is any patient that is brought to Enniskillen with potentially surgical pathology and they're seen by the surgeons and that is ruled out, we have a rapid transfer protocol that allows them to be repatriated to South West Acute Hospital. My colleague, Dr. Monaghan, has set that up, and it works in practice really well. We've actually got an identified team that accepts all of those patients back. So, as I say, while I do accept there will be patients who do go to Enniskillen that, in retrospect, could have been looked after locally, we try our best to provide care as locally as we can, but for safety reasons, we have to do what's right for patients.
So, and just to go a bit further, what I would also say is that when you look at the numbers of patients being treated through our surgical ambulatory service, that started off in the first 6 months as quite low, as we were building up the competency and building up the confidence of this hospital in dealing with general surgical patients. Now we're up to over 5 patients per day being treated locally in this hospital, and that prevents the journey. So therefore, I think it's 69–70% of emergency general surgical patients come into this hospital do not have to transfer. And that's a complete reverse of where we started. So you're absolutely right, where it's a simple issue, we try to resolve it quickly, locally, and they don't have to transfer. But there are very legitimate ambulance bypass protocols. Are we busier than before? Absolutely. And we can provide the evidence of that, Chair, no problem at all. We show you in terms, no matter what way you measure it, we are much busier in terms of sessions, in terms of patients, in terms of specialty spread, everything. Because the health service needs it. Could we do more? Absolutely. I'm always open for business. I'm always open for business cases for additional, and we are negotiating as we speak for additional elective work through this hospital, I can assure you. In terms of the minimum number of general surgeons, I hope I've made the point that it's much more than general surgeons. To reinstate emergency general surgery requires a range of specialties, a range of additional people. So we are on record as saying, yes, you need a minimum of 6 substantive general surgeons to maintain a rota of emergency general surgery. However, there's much more to it now since the new standards were issued. And it's all about the other specialties and the other clinical interdependencies is what they called it in the standards. And I think that is, we've had a frank conversation about that already today.
Yeah. So if 2 general surgeons walk through the front door tomorrow and said, we want to work here,
well, we would.
It's not going to solve.
Well, but be clear. We'll be open to a conversation.
Oh, you take them. You take them.
Open to a conversation. If somebody wants to fund me for an additional 2 general surgeons, I would grab them tomorrow. But remember, we've no vacancies. A consultant, for the first time since a Western Trust was formed, we have no vacancies at consultant general surgeon level. And that proves to me that if you get the rota right, if you get the job plan right, you will attract no matter where you are. And that's been our problem. That's the point I made. If you've got small rotas and if you don't have the juniors coming through, who get actually access to your local hospitals, they're not used to being here, and you won't be able to attract them. The modern age, and I say this frequently, for a 1 in 4 or even a 1 in 6 rota, if you've got a married couple, both being doctors, that means 1 in every 3 weekends, they're not allowed to go beyond half an hour from the hospital. They're not allowed to take a glass of wine with their tea, any day. It's a big lifestyle issue. Whereas if you're in a 1 in 14, what is it? 3 or 4 times a year, you're going to be doing on call. It becomes a completely different life. And that's why we've struggled to recruit. It's a completely different job.
Well, thank you very much. It's been very informative. Thank you.
We can provide more information just on that activity if the committee
would find it helpful. I would love to.
And just maybe to add that obviously with the elective care plan and the additional funding, mainstreamed funding that is now being given to trusts, we have a CT scanner here which has never been fully used, and we've been commissioned this year to do 10 sessions. With that, we're looking at a 7th gynae consultant. So there are real on the ground changes that are happening, new investments and extra busyness coming to the hospital as a result.
Thank you.
Okay, thank you. Linda.
Thank you, Chair. I'm not sure Diane might have had her hand up before me.
Go ahead, you're on the list here.
Okay.
You're on now.
Mine is actually only all of my questions, bar one, have been answered. And the last response kind of alluded to a wee bit of it. And my particular concern is around female women's health and the fact that it is neglected, wouldn't even start to describe what it is. But as far as I'm aware, the only specialist around endometriosis is in the Western Trust. Is that right to say that?
We have a non-commissioned regional service where we have 2 surgeons who do provide that expert care.
And do you have the other surgeons that are very often required in terms of, colorectal and renal?
So what we've done, because the endometriosis surgery is exceptionally high risk, the complications really are bile perforation. It's a big one. So we have job planned colorectal surgeon to be present for all of the endometriosis surgery, and they all take place in Altnagalvin, because there is also issues with urology. You can damage a ureter, and you may also need intensive care as well afterwards. So we have a safe endometriosis surgery procedure and policy in place.
So can I just ask, was there a business case put to SPPG that wasn't accepted, or did you just decide we're going to do this because the chances of the department commissioning are little to none?
Don't answer that.
Well, no. So we had a surgeon who actually, an obstetrics and gynecology surgeon who works in Southwest Acute here, who had a special interest in that, and he wished to develop the service. So we were very keen that this service was developed for the population of the Western Trust and Northern Ireland. We are, however, working with the SPPG to have the service commissioned.
And if I could just add, Linda, when we talk to the Commissioner, and we don't have absolute agreement on this, there is a view that endometriosis is a general gynae procedure. We think it's a very specialist procedure, and obviously some ladies are very, very complex. But the fact that we've been using core commissioned services to deliver an endometriosis service hasn't been queried, particularly by the Commissioner, because it falls within gynae services overall.
Well, I suppose on the flip side of all of the agitation that there has been in this meeting, I want to say fair play to that surgeon, firstly. Not only is it not a general gynae issue, it's not a gynae issue. It's much, much wider than that. And it is a specialist service that is required. So, Chair, I would appreciate if we could, and I know this is something we've done previously, but if we could write to the department to ask, or write to the Minister to ask what they plan to do in terms of going forward in a specialist endometriosis service for the women in the North.
Particularly the West, hopefully. Sorry, that would be great if you could support us in our business case.
I want you to, I don't mind if you're the only place that does it, because right now women aren't getting it at all.
Yeah,
I think they'd be more than happy to travel to Fermanagh if they thought that they could get the special service that they actually require. With all of the specialist services that they require, that includes specialist nurses and the other surgeons that are needed and the other services, because as you've outlined, it is not just gynae, it is very serious surgery, and it is specialist.
Chair, could I maybe suggest there are discussions ongoing about commissioning of endometriosis services between ourselves and the SPPG, and I wouldn't like any impression left that this isn't a very active issue that's under consideration. I just am not over the detail of all of it at the moment, so I'd be very happy to send something into the committee just about the position as it sits at the moment, and then maybe you want to take it from there.
No, I think that would be...
No, sure, I'm content that we do that, then we wait until we get the information, and it's really updates we're looking for then, if this is an active conversation and something that's hopefully is going to be developed. I appreciate that, thank you.
Okay. Diane?
Yes, thank you, Chair. And thanks for the presentation, and actually for all of the information. It's really, really useful. So this whole conversation, I think, has provided probably two light bulb moments for me. One is that, really, as the old saying goes, it takes two to tango when you're talking about All Ireland healthcare, and that the people that might not want to tango are not necessarily all in Northern Ireland. But secondly, and more importantly, and this is very important, I suspect that people watching this will be completely annoyed by what they have heard today. Because what we have a situation is where we have trust representatives, and I respect your honesty in this. This is actually really, really revealing, where you're actually saying, I had to close emergency general surgery because it was an emergency and therefore it had to end. So it wasn't a temporary cessation. And then I actually had to consult on the permanent closure. But it wasn't really that, because actually we couldn't open it again in the way that it was. So none of it was real. We took a decision, and the decision is the decision. And then we have the Minister saying, no, you have to halt that consultation because you haven't consulted enough on a permanent closure of something that you say you couldn't restart. How on earth are people meant to have faith in that system?
Somebody going to answer?
We're waiting for a question, Chair.
Well, I've just asked the question, Chair. How are people meant to have faith in that situation? I mean, I just
apologies, Diane. I thought it was a rhetorical question. I wasn't trying to be smart. I wasn't trying to be smart.
I want to know exactly So the people listening to this, and there are people listening to this, and they'll be listening to it very intently, and they've just been told that the minister says, no, it's the trust. And the trust says, well, like, we're actually told that we have to consult on a permanent closure of something that's gone. We can't reopen it in the way it was, so it's gone.
I suppose the
what is this all about? Why can we not be just open and honest with people?
I believe, Diane, we have been open and honest. Yes, we've made mistakes in terms of some of our arrangements, but there's at no stage have we ever issued information that was in any way misleading, in my opinion. However...
No, you just give me a second. You've just gone to great lengths today to tell us that actually the original consultation on temporary closure, because it wasn't really temporary closure, it was emergency closure, that wasn't real. And then you've also gone to great lengths to tell us that actually the consultation on permanent closure, that wasn't real either, because actually we couldn't open it.
So I'm happy, Dan, to come in. Consultation and involvement is a statutory responsibility of all HSE organisations, and we have a consultation and involvement scheme which is signed off by our board that makes commitments to engage and involve with our public where we make significant changes. In addition, so that's a legal requirement. So in addition to that, there is a departmental circular that places more detail around that and places specific requirements on HSC organisations, trusts ourselves, SPPG, the department itself, PHA. And that circular deals with both what they call temporary changes and permanent changes. Now, it's a little bit complicated because the circular actually has changed over time. But at the time when the temporary change was made, and we called it the temporary change in line with the circular, to be in line with the circular, we did check in with the department about the need to consult. And the department advised us there was a need to consult. Now, what did we consult on? Our first consultation, the consultation on the temporary change, was not about whether the change should come back or not. It was to reach out to the public to say, is there anything else that we can do? We have had an emergency situation. We were very clear about, we had no consultants. We were clear about the problems that we had, and we were clear about the new standards. And the ask was, is there anything else that we can do? Is there anything else that the public would suggest? I mean, there was a by way of, we just want emergency general surgery back, and that is entirely understandable, because it's a very, very difficult consultation to do, to go into a situation of, let's face it, people felt very strongly a loss of a service, and there was a loss of a service in a way, although that service had been re-provided to the public in a very safe way, through an ambulatory provision, remaining here in South West Acute Hospital, and an inpatient pathway which went to Altnagelvin Hospital. So Diane, it was an odd situation really from the get-go. The permanent consultation, I mean, we are required under the legislation to consult on a permanent change. It's very difficult to do that when the change has already happened. And all of the evidence would show, and it did show, and we covered this in the consultation document, all the evidence would show that the service that is now provided is safe, albeit there are compromises around patient experience, and we totally accept that. Although we are now monitoring patient experience much more closely, and patients are starting to engage with us and giving us comments about that service, and they are generally very good comments that we receive. So I can't, Diane, unravel this into something that feels like a more normal customary consultation process where you give people lots of choices. It happened in the way it happened because of the circumstances that we were in and the legislative requirements that are placed on us and the requirements that the department itself places on us. I think it's quite an unusual situation in Northern Ireland.
Sorry, my apologies. My dogs are not in the room with me, but they are very, very loud if you keep hearing them. So my apologies. I just think that one of the things that we have to do, if we are to convince people that transformation is possible, and indeed we all agree that it's necessary, we have to be honest with people. And I'm not sure that that's where we've been, but we'll leave that, we'll park that one for now, because I do actually think that that's important. So then, whenever the minister tells you to pause the consultation because you haven't done the consultation right, I'm presuming everyone is aware that this consultation in the Trust's view only has one end product, and that is to continue with emergency surgery at Enniskillen, because the depth of feeling in Fermanagh is such on this. It is my understanding that out of the 30,000 responses to the hospital network consultation, around about 27 or 28,000 of those came from Fermanagh. Now that is some community mobilisation, and fair play to those that organised it, but it shows the real depth of feeling in this.
Sorry, Dan, could you just repeat the question for me, just please?
Sorry.
I was following your train of thought, but just your question, please.
So how are you going to consult on something which I think is evident from this conversation today that the Trust has decided is a done deal? What does the new consultation look like? What are you talking to people about?
So the consultation, the formal consultation on emergency general surgery was paused in July after the letter that was received by the Trust from the Minister. And in October, the 7th of October, Trust Board met and agreed that that consultation would not be paused, it would be closed. The Minister asked that we commence visioning work, of course to include SWA, but also to ensure that we fully outline the needs of the population of Fermanagh and West Tyrone. So the work that we want to do, Diane, is broad work across primary, community, mental health and hospital services to understand fully what this community values, what we can do to change services to services that they feel they need and value more within the hospital and outside it, because we span all of those areas in our provision. Primary now with the 3 practices, obviously community, mental health and hospital. So it is to broaden the conversation with the public rather than view this as a consultation. We don't view this as a consultation, we view this as a piece of work that helps us understand and agree and co-produce with our public a vision for the future for this area across a whole range of services, Diane. We think that in that way we can set what a hospital needs to do within a community, within the needs of that community and with clarity about what that community values.
Okay, so, and again, this is important because, I mean, I think this is probably the first time that people have had this really open conversation with people in Fermanagh. There's absolutely no doubt about it that the degree of travel time and the feeling of being bereft and neglected by the Trust in taking services away from the hospital, and the fact that the Trust has a hospital where some of those, or 2 of those theatres, they're not properly commissioned. They're used for the elective framework, but they're not commissioned theatres. It's a bit of a mirage to say that we've commissioned the 2 theatres in the SWA, because actually they're only used for that elective purpose. And there's no investment in nursing staff as well. Is there going to be, in this conversation, and I must say I think Helen and Jimmy are completely right in that they want to talk about bringing back emergency general surgery, and you want to have an open-ended conversation on a wider vision. And I don't know where that meets in the middle, is the honest truth. But is there any intention of having a vision for the SWA that will invest in doctors, in nurses, and in specialisms that will keep the hope of broadening and deepening healthcare in Fermanagh alive.
So I would very much hope, Diane, that the conversation that we have with the public would confirm a lot of the things that we know about this geography, and we've referred to them today already. We have a population that is growing older, as it is across Northern Ireland. We have fewer young people in the population as a workforce. We have, with an older population, a great deal of need across a whole series of disease areas. So diabetes, respiratory, renal, heart failure, but also loneliness, wanting to stay at home and have your care at home. I mean, when we wrap around people in a geography, it must be a full conversation, and we would really like to do that. It isn't something that's ephemeral. It isn't something that we will do for the sake of doing. We want to shape services that will suit the population of Fermanagh and West Tyrone. And that is a population that is older and has a range of multimorbidities and needs, who wants to stay in their home and be supported well or cared for well locally in another setting. So I think, Dan, just to kind of complete the issue about the two theatres, I mean, we would absolutely, in this role, and in my linkages with the Commissioner, and everyone knows this, have been pressing for investment to expand our theatre utilisation here in the South West Acute Hospital for a long time, including during COVID. For the first time, really, we have seen mainstreaming of waiting list initiative money, and that is now benefiting us. And I talked about the CT scanner here, I talked about the 7th consultant here. That is going to benefit people from across the West, not just in South West Acute Hospital, but across the West. We really need multi-year funding, multi-year budgets, in order to work with our independent sector providers so that they can plan and to use our theatres. And we need investment to make sure that can work well, efficiently, productively, and with good value for money, because in-year money is really not the best way to spend our money. It is very, very good to get any patient off a waiting list, and I would never refuse the opportunity to do that. But we would like to plan much longer term, and if it's not possible right now to build capacity ourselves with nurses, doctors, surgeons and the rest, then at least let us do it with the independent sector over a reasonable period, so that we can have a steady and reliable service and chip away at those waiting lists much faster.
Can I ask a couple, just a very quick question? So, are you still transporting patients to Altnagelvin in private ambulances?
We have 2 crews that are available here for transferring patients to Altnagelvin. One is a late morning to early afternoon crew, and one is around a lunchtime, I think, to late night crew. If they are not utilised for transfer of patients for emergency general surgery, those crews are utilised, as I understand it, Diane, to support local discharge of patients. So they will take patients to their homes or their nursing homes. So we attempt to utilise them as much as possible.
So are they Northern Ireland ambulance crews, or are they private?
They're private crews.
So so you're still using private,
correct,
unregulated ambulances to take people to Altnagelvin? Am I correct in saying that?
The decision about the suitability of a private ambulance as opposed to a Northern Ireland Ambulance Service ambulance is a clinical decision. It is based on the presenting patient, as I understand it. Brendan will keep me right, and the risks associated with that patient. No clinician here will ever have a private ambulance used that's not suitable for the patient presenting. I don't know, Brendan, if you want to add to that.
Yeah, so just to say, really, private ambulances transfer patients between every hospital in Northern Ireland on a daily basis. So this isn't something that's isolated to movement of patients between South West Acute and Altnagelvin. And if you don't mind, I'm just going to go back to your previous question. You asked about expansion of services. Since the temporary cessation of emergency general surgery, we've introduced breast surgery, ENT lists, which were never previously here. We have visiting surgeons, some of whom are Western Trust and some of whom are outside, who come and do gallbladder operations. We are trying to expand our upper GI elective footprint here. As Teresa's mentioned, we're appointing a 7th obstetrics and gynecology with the hope that we can start to increase the amount of elective gynecology work, because there's huge waiting times for women who are waiting for elective gynecology procedures, and potentially try and make this a regional centre because of the spare capacity we have in theatres. We're also looking at our trauma and orthopaedics colleagues and moving what we can from Altnagelvin out to both OMA and Southwest Acute, and we're in discussion with those consultants at present.
And again, I think just if I could add to that, the agreement that Brendan has secured through his own initiative with NIMDTA to, for the first time ever, place resident doctors here. One of the huge problems, again, in recruitment often is that if people don't have the experience of working in an environment, even though jobs are advertised, they won't come to them. So by bringing residents here who, as part of their training, spend time here, you build a familiarity and a sense of this community, which is very vital and very powerful. And then they see a place they want to stay in, or they meet someone, a partner that they stay in. So one of our problems here is getting NIMDTA to acknowledge that there is really high quality learning and training in this circumstance, which in itself enhances the morale of the place and gives that sense of a developing dynamic scenario. Brendan now has got agreement that that will commence in August with the intake of resident doctors.
So just to clarify that, so
that's a brilliant segue, Tom, into my next question, which was really within the new cohort, the original cohort from McGee. Yeah. I presume qualified in the summer, if I'm thinking right. And how many of those were we able to retain in the Northwest? Do you have any idea? Did the Trust employ more?
So they've been employed across Northern Ireland. My understanding is that we have 10 of the McGee graduates who are currently working in the Western Trust. Just also go back to Tom's point, what I've done is, with the help of Dr. Monaghan, we've set up a pilot project with the agreement of the Chief Executive of NIMDTA to bring Tier 3 medical doctors. These are quite senior resident trainees to the Southwest Acute Hospital. And this would be a huge development, because if we can get these doctors on site, it will mean it should be much easier to get permanent consultants as well.
Well, that's encouraging. That is really encouraging, because we really do need to invest in the workforce, not just, doctors, not just having consultants, but we need the whole remit of the workforce that we invest in. Can I just ask, there was a question mentioned today that there was some indication that there might be a downturn in elective surgery in the SWA over the winter period because of winter pressures. Now, I know that happens across Northern Ireland because just of the sheer pressure of numbers in the hospital. Is that likely to happen?
So,
go
ahead.
Well, I do unfortunately have quite a wide portfolio on emergency planning and business continuity. Diane is part of it, and what my team do is they support the winter planning preparations, although we now call them escalation plans. So very many of our patients, particularly at Altnagelvin and Southwest Acute Hospital, are clinically urgent patients, so they have conditions that make them time critical. So cancelling elective patients is an absolutely last step that we would take. And I mean, I've seen the efforts that our team make. We have a very, very tight, well-coordinated process which looks across our hospitals to make sure, it's called our coordination hub. It looks across our hospitals, it looks at all of the balancing factors when pressure builds in our hospitals, either in our ED, in our wards, or with our delayed patients. And there will be judgments made, which will sometimes actually be made at a level of our corporate management team. At those points in time, we would be into what we call our silver escalation, and we would assemble our silver command and control arrangements at trust level. So decisions about cancelling really get to a very high level within the organisation before we would ever, approve them. And I know we cancel tiny numbers of patients for elective procedures who are in those clinically urgent or time-critical categories, Diane.
Have you reached that silver status this autumn so far?
We have had, I think, a series of about 4 days, probably about four weeks ago, where we did run silver. To my knowledge, no patients were cancelled over that period. And in those instances, a director will step in and will chair silver. It's a short meeting. It is to support the operational staff in decision making and escalation issues. And I mean, it really is a sight to behold how our operational and clinical teams pull together at times like that to ensure safe care and to ensure that the impact on patients of that very high pressurised situation is minimised.
And Diane, the 8 beds that I talked about in trauma are designed to actually help protect elective work during the winter period, because some of the pressure in relation to the emergency work is through trauma, and the general sort of conflict between trauma and orthopaedics. So to try to protect the elective work in orthopaedics, we've actually got commissioned 8 extra beds in trauma, and that then helps the flow of elective, so it helps protect the beds.
Can I say thank you? For those who know me, I just say the thing as I see it, and I think that people need to be spoken to about this particular issue, which is very vexatious in Fermanagh. And I know I don't live in Fermanagh, but I have a large cohort of family who do. And they need to be spoken clearly and particularly honestly about what has happened and what is possible for the future. I think that many people in the area feel abandoned by the trust, and I think that there is a huge amount of work to do to repair relations. Thank you very much.
Chair, could I ask a yes/no question just on
Go
the
ahead.
back of that? Just and I've held off going to my next appointment to be able to get to the end of this. Can you give an assurance on a yes/no basis that there are no current discussions or plans to remove any other services out of the South West Acute Hospital?
Yes, I can give that assurance. Because, sorry, can I qualify it to say certainly no discussions involving the accounting officer of the Western Trust. So I don't know what other conversations other people can have. Yeah. I can only assure you in relation to any conversations with regard to the Trust, I would be astounded, because look at the great work this hospital is doing. Look at the fantastic, how we're expanding the specialties in this hospital. So why would anybody wish to take away any services from this hospital? I can assure you in that, Colin.
And that's really good, because there can always be a nervousness.
Oh, absolutely.
And
there's been
starts the process.
There's been a lot of talk.
Absolutely. That's good.
And just finally, anyone who walks through this facility, it is leading edge, probably the most modern hospital building in this region, significantly so. And by the way, it's operational, unlike some other new buildings. And the people in it take huge pride in it. And it depresses me that they would feel despondent or feel a sense of not being valued, because there is nothing further from the truth.
And the water system works.
Okay, that has been a long session, but I think it's been worthwhile. I said there was 17 or 18 issues that I had wrote down. The majority of them were covered, and we thank you for the time that you have given us and the answers that you have given us in relation to it.
Thank you.
Can I check, Chair, if you have any further questions as Chair of the Health Committee, please feel free to contact me. I'm happy to give you any information you need.
I mean, there will be ongoing issues. We will be engaging with the department, I imagine, in the aftermath of this, so we may well come back to you on some of the items that we have raised with you. But for now, thank you very much. Okay, members, so We are moving quickly to item 8 on the agenda, written briefing, home care services. Can I refer members to the written briefing from the department on home care service, page 63. Does anybody have any comments?
No, but was that action taken from that last session about writing to the department about what's temporary, that's an action that's been taken?
Yeah,
sorry. Are we at the end, but that's okay for that.
I'm actually going to draw back. We should go through that.
Just in case there's anything else.
So I think we'll have to maybe do something in relation to the figures and the statistics. I know the Minister has written to us, but there's still a wee bit of confusion. It might take time to read what the Minister has written to us just in regard to that for figuring what we do that next week.
I actually think an oral briefing at the committee about what are the procedures for temporary closures and what it means and how the consultation rolls out, because if what we have unearthed today, and I think certainly Diane followed up on it as well, I think we've created a system that is constantly just going to put decision makers and the executive at absolute loggerheads with the community, and I think there needs to be a different way to look at that system that everybody can kind of have a fair go at it, but it just doesn't seem right at the minute. There just seems something wrong with it.
Okay. Can I maybe ask Keith, if you go through some of the things that we potentially need to do in the back of that?
Yeah, certainly. So there was that issue of the procedures around temporary closures. There was the issue of the commissioning of the of the beds, whether that was trust or SPPG, and they were going to come back with further information on that. There was figures in relation to the numbers of consultants at Alton, which they were going to also come back on. In relation to the endometriosis service, again, the trust were going to come back with some further information in relation to the business case, and then we would consider what we would do after that. That is, I think that's everything I got during that session.
And I'm a bit cautious, Colin, about further orals, because we've actually, because of the length of time that we took with that, we've actually shifted something that was on today's agenda. So I think we need to be careful. I mean, because, and I say this every week now, and I've come to this realisation, everything that we get a briefing on is important. So I could have reduced that to an hour, but then there would have been 20 issues that we wouldn't have got covered.
Written briefing would do, but a good, decent briefing from them, not just like a letter back saying stuff if there isn't.
Okay. So everybody happy with that? Then moving on. Sorry, Dan.
So sorry. I just think it's actually quite important to actually ask the Minister what is the vision for the SWA within the department. Now he'll say it's the trusts, because I mean we've just heard the trust and the Minister. They're just batting stuff around, and in the middle of it all, there's a community that says services are being removed from my hospital, and that makes me more vulnerable. Now, some of that may be perception, some of it is reality, and certainly if you're on a farm at Rosslea and something happens and you have to get down to Gelvin, it's a very long way over very poor roads. So I would really like to keep the pressure on around this visioning for the SWA and how we can build up a health service that meets the needs of people in County Fermanagh, because it is our most rural and probably most remote part of Northern Ireland, and I think people, well, my view is that people feel a little bit forgotten about in the middle of it all.
Yeah. Okay, so we're going to write to the Minister and ask him what his department, his vision is over and above what he's asked the trust to do.
Yeah.
Okay. So the written briefing at 8 on home care services. Anybody have any commentary on it?
Sorry, Chair, other than to say it's, I just can't find it now, but I had made a note to say that it is actually quite good at explaining the number of beds that are required and the extent of that social care problem that we were talking about and that the Trust were talking about.
Yeah, I mean, I was shocked in the walk around.
So it's page, sorry, I had a note about it, and you had a note, page 68, paragraph 20, which contains the Northern Ireland-wide figures for those waiting on packages at the end of September. And that's the extent of the issue that we face going into the winter. Yeah. So I'm just not nimble enough to get it all turned up. But
1,806.
Yeah.
Yeah. I was just saying there in the walk around today, one of the doctors talked about a patient who was in a bed here for a year waiting. I mean, that's a year.
Shocking.
Yeah. Okay, so there's also a written briefing on the cancer strategy. That's at page 72 of the pack. I don't know if anybody has any commentary on that.
Sorry, can I ask a question on that?
Yep.
So we had the debate on cancer waiting times the other week, and then one of my colleagues asked the Minister a question about cancer waiting times during questions, and he was asked would he bring forward sort of like a short action plan that would be very, very specific, because clearly the elective care plan isn't dealing in its totality with the issues around cancer waiting lists. And I think he indicated that he would, so it would be quite useful for the committee to ask him if he is minded to bring forward an action plan in relation to cancer waiting times, which are appalling, and how soon can we see that action plan, and will he devote some more of his elective care funding towards it?
Yep, that's...
In my view, if everybody would agree with that. Yeah. Sorry, I have a whole list of things.
We're not at home and it's 20 to 6.
Yeah. I know. I'll be very
soon. So we're definitely all going to get the correspondence item number 10. So can I refer members to the correspondence list at tab 10.1 of the main pack at page 79. So can I remind members this list contains both this week and last week's correspondence. So if we're going through it, I mean, just in terms of 10.6, I mean, there's correspondence in relation to the mother and baby unit with the potential to look at something temporary, which I think would be welcome. I certainly think that should be explored. At item 10.20, there's a response outline work that hasn't commenced yet in relation to the Adoption and Children's Bill. I don't know if anybody has any commentary in relation to that. No. Okay, at 10.25 is correspondence from the Chief Executive of IHCP in relation to the real living wage. So on Monday, just in advance of this, because we're aware of the media, I had asked the clerk to contact the private office to ask further questions in relation to the figure the Minister used last week and to seek clarity on the number of workers that are paid the real living wage. So we haven't received that yet. So I mean, I think we'll all be very interested to receive that. I mean, we were all in committee last week when the Minister gave his answer. I think it confused all of us at the time, and it certainly didn't stand up to media scrutiny this week, so that will be interesting. Now, he's obviously agreed to meet with the independent sector. I don't know if that meeting has taken place yet, so there might be some meeting of minds in relation to that, but anyway, I think it's important correspondence that we're awaiting in relation to that. Have members any other commentary on the correspondence or any issues that they want to actions? Dan? I don't know if you're saying 5 or just you're waving there.
No, Colin will be even more grumpy than that.
He's getting there.
So just as page 119, it's the Tobacco and Vapes Bill. So there's a letter in from the Windsor Framework Democratic Scrutiny Committee, which says that there is some doubt that the Tobacco and Vapes Bill would apply to Northern Ireland. We've already given our legislative consent to its application in Northern Ireland, so it might be useful to write to the Minister for clarity, whatever, if he has any.
I think the issue was actually raised during the debate in the chamber, I remembered, but it does no harm. Just I think the Minister did respond at that time, but I think we can contact him again.
Yeah. The other stuff, I think, well, we'll let it wait. That's Thank you.
So, I mean, there are a list of actions. I mean, it's important. There are a list of actions assigned to some of these correspondence. So, if everybody is in agreement, then we'll agree with that. Okay, and then just forward work programme. So, in our table pack is a draft press release in relation to our visit today and the various events that we held today. Members content with it? There's nothing earth-shattering in it? No? Okay. Forward work programme 278. Are members content with the forward work programme? Okay, so everybody's aware Tuesday inquiry report has been issued. Sorry, the inquiry has been issued to all members of the Assembly. So our debate is on Tuesday afternoon, and everybody's going to receive an invite to attend the launch of events. So obviously I would expect everybody in the committee to attend and encourage our party colleagues, not just to attend, but even to participate within the debate. I think that would be useful. Okay, and there again, there's a draft press release in relation to the launch of the report, if everybody's content. Any other business?
Yes, can we ask if Diane's dogs have been fed? Because I'm sure they're parking rightly there.
Sorry, Dan, you did. I don't know if you're meant to be comedic in this when you talked about the light bulb moment, because you've been sitting in the dark all day. So you may not have found it funny, but certainly we found
Two
it.
light bulb moments. Well, switch them on.
That was it.
You know, and I always sit at this table with just my table light on. I don't know why I do that.
Nigel needs to put another 50p in the meter.
Okay, anyway,
You get away home, Colin.
we need to move on before we say something gets us all in bother. Date, time, place of next meeting is room 29 next Thursday, 2 p.m. Thank you very much.
Thank you.
Meeting adjourned.